Good evening to all, and welcome you all to this session of ISG meeting. This is in July next. We have a very interesting set of case presentations as well as a very interesting topic for today that needs to be discussed on GI cancers, where I think there is a lot of lacunae from the medical gastroenterology department where we don't know what much is happening. So I think we'll start off. We have a long list of programs that needs to be started up. So I would request Professor Eapen, President Tamil Nadu ISG, to come over and deliver his welcome address. Then we'll begin with the formal postgraduate presentation. Thank you.
Pleasure to welcome you all to this month's edition of our TNISG monthly meeting. I do not know what to say each time, so I bring some cartoons each time for 3 minutes, but they'll all be liver orientated, so you have to bear with me. So it's basically in patients with liver failure who we look after. That means they are all medical treatment options of acute liver failure or acute and chronic liver failure. When people improve, or when they are somebody very sick and near death and they come out of it, that is the topic. Just a few points to think about. Would you call it liver regeneration? Because there's a lot of interest in stem cell therapy, etc. So, or is it just recovery of the organ function? So this is often referred to in this scenario. This is a Greek mythology where one god called Zeus became angry and his enemy was Prometheus. And he nails him to a mountain and then sends an eagle to eat his liver, which doesn't die, and every day it replenishes itself. And this is the reason why one of the liver devices is called Prometheus device. They've caught on to this name, etc. So it says that the liver would grow back daily, every day. And tomorrow again the eagle will eat, again the next day it will grow. That's the, so let me present to you the idea that the Greeks were wrong. That's the thinking. So cells in our body has got half-lives. So I was amazed when I went through this. I didn't think so. So let me say what So what are the half-lives of these? So we know that in the gut, the enterocyte, so small intestine and large intestine, the enterocytes and colonocytes is 5 days is the turnover. That we all are familiar with. Okay? And RBCs is 120 days, 3 months, we know it. And there are different white blood cells. For example, mature neutrophils is only 7 hours. And platelets are 7 to 10 days. The question is about hepatocyte. I will say I didn't know it. So to me, Prometheus is in the head and every day it regrows. Okay. Now the neurons apparently lives longer than the human being. If a person dies also, the neuron is still alive. And if you take it out and transplant somebody else, it will still live. So neuron is a very long-lasting cell, can live longer than the host. The hepatocyte is 5 to 6 months. It is not overnight regrowing. It is not the 5 days of enterocyte. That's something which I didn't know. Okay, so that's against this concept. Why did person is improving, and Prometheus picture is there in our head, and is every day regrowing is what that picture said. We know that in liver the endothelial cell is also important, and those are in the whole body. There are different wide spectrum from 2 weeks to 1 year's time. So that's the first information which was not fitting in, that it's not a rapidly turning over organ, it's the cell. So in fact this write-up in the Scientific American says that every 80 days, 80 to 100 days, in our body all the cells will change. Okay, but for I think the neuron, everything else changes. So it's not me 80 days later, somebody else here. All the cells are changing. But the rapidity of turnover are very different. So liver cells do not come in the rapidly turning over cell category. So looking at the garden, and all of us who have time to do it will, I'm sure, have this passion. So in a surgical resection, hepatectomy, we are removing some of the branches. That's what's happening. But in the medical problems of liver failure, it appears that the problem seems to be obstruction of the flow of the sap into the different branches of the liver microcirculation causing liver failure. And this phenomenon of a plant being in the morning healthy and by evening it's wilting is commonly seen. And these are all highly studied in those circles. And it's because they get dehydrated. And if you water them in time enough, the plant perks up and becomes very quick. We all see this in our garden. But if you're too late to do it, the plant may die. And when they are dehydrated, if you shake them a bit or blow hard at them, they may start flying off. And I think that's what's happening in acute liver failure. I'm not going into that. But it's true that the plant, which is wilting by evening, when you just water it, is again getting revived. And especially in the colder climates, there are 4 different seasons. And in autumn, it's called fall because all the leaves fall off. So, and there are new leaves coming up in spring as well. So it appears that this is the phenomenon we are seeing in the medical problems of ALF, ACLF. And when you think of it, there are a lot of applications around this in our thought process. I'm not going into it, but I'm just saying that it appears that it's not the liver regeneration of Prometheus in the picture. It's more what's happening seems to be this phenomenon of the flow of the sap in the branches of the liver microcirculation. So this is my last slide. So the better term for medical treatment of ALF and ACLF, which are most of the patients under our departments, is not liver regeneration. That must be happening later on when the person survives, maybe over a course of a month or 5 months, 6 months. But what's really happening is like this plant wilting, where is only a functional recovery. And it may be equivalent of the dehydration of the plant and the wilting of the leaves and the flowers, where it comes on. Thank you. So that's my 2 bits for today. So let me stop at that. And as Pirma said, there's a packed agenda today. So may I hand it back to Pirma to kickstart. Thank you.
Postgraduate session, I'll request chairpersons, Dr. Shanmuganathan, Dr. Raghavendra, Dr. Arun, and Dr. Sheshatri to take the stage and conduct the proceedings, please.
Presentation. Good evening, everybody. As the mic is coming over there, I just start off from here itself. We'll start off the PG session. My co-chairs, Dr. Shanmuganathan, Dr. Raghavendra, and Dr. Arun will take over. So the first case is Double Trouble by Dr. Venkata Sriram from SRMC. Let's see how we manage the double trouble. Whether it's personal trouble or patient trouble, we don't know.
Good evening. This is Dr. Sriram from Sriram Chandra. Coming to the case, a 83-year-old male from Arakonam came with the chief complaints of upper abdominal pain since 2 months, anorexia and weight loss since 2 months, and vomiting since 1 month. So history of presenting illness, a patient came with abdominal pain since 2 months, which is insidious in onset, gradually progressive, dull aching type, upper abdomen more in the epigastric region, mild to moderate in severity, felt 15 to 30 minutes after food intake. Relieved with hot fluids, and sometimes patient vomits and get relief from pain. There is no radiation of pain to back or chest, no change in intensity with change of posture, respiration or on movements. There is a significant weight loss around 8 kgs in 2 months and loss of appetite and excessive fatigueness. Patient had vomiting, which he noticed 1 month back, occurring 2 to 3 times per week, about 1 to 2 hours after food intake. Vomitus consisted of undigested food with no blood or bile and quantities around 50 to 100 ml. There are no complaints of bleeding per rectum, melena, or no complaints of jaundice, fever, or decreased urine output. Patient had dyspeptic symptoms on and off for the past 30 years and hunger pain in epigastrium, which is relieved with food. Patient is known diabetic and hypertensive on medications. There are no history of surgeries in the past or no risk of high-risk behavior. Treatment history, patient has been taking medicines and antacids since the onset of presenting symptoms and had partial relief of symptoms only. and had referred for further evaluation. Family history: married for 60 years, has 3 children, no significant illness in other members of the family. He's a smoker and alcoholic who takes 3 to 4 units in a week for the last 30 years. Patient appetite was reduced and bowel is constipated, micturition is normal. Sleep occasionally affected due to pain. Patient takes mixed diet. He takes soft solid during the last 1 month after the onset of symptoms. Patient calorie intake is 900 kilocalories and his performance status is ECOG 2. On examination, patient conscious and oriented, vitals were stable, and systemic examination, per abdomen is soft and liver fell 2 centimeters below the right costal margin in the midclavicular line and firm in consistency with smooth surface. Spleen is not palpable. So summary: 83-year-old male, known diabetic and hypertensive, presented with dull aching upper abdominal pain, anorexia and significant weight loss for the past 2 months with non-bilious vomiting since last 1 month with ECOG performance 2. We initially thought of a gastric malignancy. Other conditions could be a gastric lymphoma, a GIST or NET. His basic bloodline basic investigations includes a hemoglobin of 10.6. His ESR and CRP got elevated and his creatinine was 2.1. His total protein is 5.4 with there is an AG reversal with albumin 2.2 and globulin 3.2. Other investigation, his tumor markers got elevated and ultrasound showed an increased renal cortical echoes. We planned for an UGScopy which showed an ulceroproliferative friable growth with overlying slough and necrotic tissue visualized from the proximal body along the lesser curvature extending semi-circumferentially till antrum involving the incisura. So the histopathological examination showed so this is a gastric mucosa with adjacent infiltrating neoplasm arranged in a glandular pattern lined by composed of atypical cells. There is a pleomorphic pattern we can see. There is a small nucleus and there is a large nucleus. And this adjacent area showed sheets and nests of tumor cells with increased mitosis. So IHC is positive for synaptophysin. So the Ki index is 80%. So final report was a moderately differentiated adenocarcinoma with adjacent carcinoma showing a neuroendocrine component. We further investigated the patient with PET CT, which showed FDG effid wall thickening seen along the lesser curvature of the stomach from the gastroesophageal junction extending up to distal body of the stomach. And the pylorus, antrum and duodenum, rest of the small and large bowels appears unremarkable. There are multiple enlarged perigastric lymph nodes are seen along the lesser curvature of the stomach. And the few prominent lymph nodes are seen in the pre-aortic and aortic wall. And there are multiple centrilobular nodules are seen in the tree in bud appearance pattern. So the features are more in favor of gastric carcinoma with an extension of regional and non-regional lymphadenopathy and liver metastasis. So the final diagnosis is gastric carcinoma and NET with distant metastasis. A medical oncologist opinion and surgical gastroenterologist has reviewed the patient. Only best supportive care was possible. Attenders were counseled regarding the poor prognosis. So this is a collision tumor. Collision tumors are rare neoplasms which consist of 2 or more distinct neoplasms that develop adjacent to one another and coexist with no intermingling, which is different from a composite tumor, where we can see a intermingling between the tumors. So the first gastric collision tumors were described by Jernstrom and Murray in 1966. These are few case reports of gastric collision tumors. So this is from Europe. They studied different collision tumors in different GI tracts. As in our case, in stomach, body is the most common location where a collision tumor can be located. But most of the collision tumors are like a poorly differentiated or moderately differentiated adenocarcinoma with lymphoma. But in our case, it is a moderately differentiated adenocarcinoma with a NET, which is a very rare. So this is a case report from Poland. Total around like up to till now it was around like 16 cases were reported. So the issue of individualizing the treatment is important in patients with collision tumors, as surgery and systematic treatment must be tailored to meet each patient's needs. So these needs may be difficult to define, as the two components are at different stage of progress, have different malignant capacity, and respond differently to surgery, radiotherapy, or chemotherapy. So role of multidisciplinary management is therefore critically important. So this case is being presented for its rarity, especially a collision tumor with a gastric adenocarcinoma and a neuroendocrine tumor.
A very nice presentation, a new case presentation, Dr. Sriram. Suppose, for example, this patient doesn't have any metastasis. Suppose the patient presents with such a kind of collision tumor. What would the one tumor have an impact over the other? How would your treatment options vary, and how will you go about managing in such patients? Suppose this patient doesn't have metastasis.
So here neuroendocrine tumor is more aggressive, sir. His Ka index is around like 80%. So first we have to treat neuroendocrine tumor. Later we have to go for a moderately differentiated adenocarcinoma.
Any role of this nuclear scanning in this type of neuroendocrine tumors? For PET also you are doing to assess the spread. Any
Yes,
role of Dotonox study or?
Yes, sir. Actually, the biopsy report initially came as a moderately differentiated adenocarcinoma, so we went for PET CT. After we have done PET CT, we got that report as a neuroendocrine tumor and collision tumors.
Any questions from the audience?
I think with the Ka16 of 70 to 80%, Dotonox scan may not help us much. PET CT should be adequate enough. And now with the treatments, assuming no metastatic disease, for both gastric CA being neoadjuvant therapy, you can go ahead with chemotherapy, which should take care of both, and then go for surgery later. And that will be the plan of action if it is not going to be a metastatic disease. And one of the things that you can actually find out will be if the PET is positive in a neuroendocrine tumor, most likely it is like grade 3 or neuroendocrine carcinoma rather than the well-differentiated grade 1 or grade 2 NET. So a lot of times what will happen is there will be like a well-differentiated NET, they will do a Dotonac which will be negative, but the PET will pick up like a multiple lesions in other areas, suggesting like it is de-differentiated or changed into a highly aggressive like a small cell cancer.
Thank you for the enlightening input, sir.
Next presenter is Dr. Pradeep Satya, DDHD, who will tell what lies beneath the skin, a rare case of upper GI bleed.
"12 minutes for your presentation, 3 minutes for discussion." Okay.
I am Dr. Pradeep, second year DM resident from DDHD Annanagar. The case today is what lies beneath the skin, a rare cause of UGI bleed. My patient, a 50-year-old male who presented with easy fatigability for 4 weeks and breathlessness and exertion for 2 weeks, with black colored stools for 2 weeks and loss of weight for 4 weeks, nearly 1 month. His history of presenting illness: easy fatigability 4 weeks, breathlessness, which is NIHA class 2, melena for 2 weeks. The loss of weight was unintentional and not quantified. He was able to feel he has lost a loss of weight over a period of 1 month, but there is no loss of appetite for him. And there is no history of any PND, orthopnea, or chest pain or palpitations, and there is no history of altered bowel habits or no history of any abdominal pain. Past history: this patient had a left thumb amputation done for growth at a government Rayapeta GH at 2019. Actually, his records were not available, and there is no any history of comorbidities, and there is no history of any jaundice or no high risk behavior. Then there is no addictions, no similar illness in the family. He has a mixed diet with 3,000 kilocalories and 40 grams of protein per day, and he belongs to upper middle class as per modified Kupuswamy scale. Summary: a 50-year-old male with melena and easy fatigability, weight loss with the amputated left thumb. Syndromic diagnosis: the patient has a chronic painless gastrointestinal bed loss. So mostly it will going to be a non-variceal with the features of anemia because he had a easy fatigability and breathlessness and a weight loss according to him. Without abdominal pain, any drugs, anorexia or signs of portal hypertension clinically, and the ECOG status was 1. My differential diagnosis are gastrointestinal malignancy, arteriovenous malformations, Delphi ulcer. So then we went for a general examination. Patient is moderately built and nourished. Pallor was present, and he was a bit tachycardia, and his pulse was 100 per minute, and his BP was 130/80 in supine posture. On local examination, the scar mark over left thumb was in the proximal phalanx of the left thumb is missing. Per abdomen, everything is normal. And CVS, hemic murmur heard, and PR examination done, melena was present. The black tarry, fecal staining of finger was present. Investigations, his hemoglobin was 5, anemic, and his platelet, the reactive thrombocytosis was present, and the other values were normal. All viral markers are negative, and the peripheral smear showed microcytic hypochromic anemia, and the ultrasound abdomen showed a normal study. The patient was stable with blood transfusion and is taken for endoscopy. This is the endoscopy we did. This is the endoscopy we done. Showed mild level of altered blood, and this is the growth which we see in this case. It was a black growth seen over the body. Video. And then we went into D1 and D2, and the black mass like thing was found over the D2, over the ampulla region. This is the thing. This is the thing found over the D2 region of the ampulla. And the biopsy was taken. Atypical cells with excessive melanin was found in the biopsy. Then the pathology reports showed atypical cells, excessive melanin and fibrin exudate, more suggestive of melanoma of a proximal body of stomach. Then we contacted Rayapeta GH, and we did a retrospective study and found the history of this patient. And he was found to have a lesion in the thumb. It was an acral lentiginous melanoma, for which he went a left thumb amputation at the year of 2019 GRH Rayapeta. So after seeing this biopsy report, we went for a PET scan. A HMB45 staining was positive and S100 was also positive. Then we went for a PET scan, which showed a increased activity in the fundus of the stomach. And mostly, and mild metabolically active in the pericardium, stomach was found along with. Then in the gallbladder also there was activity was found. So multiple metachronous malignant melanoma metastasis in stomach, gallbladder and ileal loops with the locoregional lymphonoidal spread was found. So the patient was by having a history of already cutaneous lesion, we found it to be a metastatic melanoma from a primary cutaneous lesion to the gastrointestinal tract. So the introduction about melanoma. Melanoma is a tumor. It is produced by a malignant transformation of melanocytes. These are derived from neural crest. Melanomas usually occur in the skin or can arise in other locations where neural crystals migrate, such as GI tract or to brain. Melanoma is most commonly not seen in our Indian continent because you are dusky in color, but it's most common in white, then blacks and Asian population. The average age at diagnosis is 57 years. Mostly up to 75% of patients are younger than 70 years of age. It is notorious for affecting younger and middle-aged population. In our case, according to our case, the most common primary lesion which has metastasis to GI tract, the primary lesion should be a cutaneous lesion, and it's mostly found in the skin, and it causes a metastatic tumor to the GI tract. Out of the metastatic size, the most common site are small bowel, showing 51 to 71% of the metastasis, followed by stomach, large intestine, gallbladder, and the esophagus. Mostly patients, these findings are found only at the autopsy because they die before they reach for the treatment. The average time from the diagnosis of primary cutaneous malignant melanoma to metastasis is 52 months. In our case also, the patient was diagnosed in 2019 and he presented the complaint in 2023. Nearly 4 years, the exact time fixed according to the literature. The diagnosis is mostly made by radiological and endoscopic evaluation. The symptoms are non-specific and it manifests in only 1 to 4% of patients with metastasis. The common symptoms are anemia and melena. In our case also, anemia was the most common presentation and here melena also presentation. The criteria for primary GA melanoma, there should be no evidence of concurrent melanoma or atypical melanocytic lesion of the skin. In our case, the patient had a 2019 cutaneous lesion which doesn't fit this criteria. So we can say it is a secondary metastatic melanoma from the skin. And there is absence of extraintestinal metastatic spread of melanoma and the presence of intramucosal lesions on the overlying or adjacent intestinal epithelium. TNM classification is a local disease stage 1 and 2, node positive stage 3, advanced metastatic stage 4. Our case is a stage 4 advanced metastatic disease. Diagnosis usually done by abdominal ultrasound, PET-CT and CT. Usually PET-CT has a higher sensitivity to detect gastrointestinal metastasis and melanomas. Endoscopic investigations, upper and lower GI endoscopy, video caps endoscopy and enteroscopy are done. Out of this, enteroscopy provides higher hand and diagnosis. The endoscopic classification of melanoma and GI tract. Thus, ulcerated melanotic nodules or normal rugae and submucosal masses with ulceration and mass lesions with necrosis and melanosis. In our case, there was ulcerated melanotic nodules or normal rugae. The classical appearance is multiple small nodules. Sometimes they may ulcerate to produce bullseye or target-like appearance. The majority of gastric metastases occur in body and fundus, most of the greater curvature. In our case, the metastases are found on the greater curvature, usually the body of the stomach. Confirmation was done by S100 protein and HMB45. Treatment, endoscopic treatment is reserved for bleeding metastatic melanoma. In this case, the patient, there was bleeding found in that site of melanoma in stomach. So we did an adrenaline injection for this patient. And other treatment modalities available are hemoclip, organ plasma coagulation, hemospray. Surgical management, complete surgical resection of the metastatic melanoma is better than partial resection. It is associated with increased survival rate and overall prognosis. Most of the patients are recovered within 6 weeks from the surgery. And the systemic treatment available are immune checkpoint inhibitors, which these immune checkpoint inhibitors regulate apoptosis and the cell death of the cell death. So these are the drugs which play a major role nowadays in treatment of melanoma. The ipilimumab, tremelimumab, CTLA-4 inhibitors, nivolumab and pembrolizumab, cell death receptor, etilisumab, avelumab, durvalumab, death ligand type 1. The checkmate trial shows that ipilimumab nivolumab combination has an increased survival rate for patients. And then mostly 40 to 55% melanomas have a BRAF and MER mutations. So drugs targeting these mutations are used now. Vemurafenib, encorafenib, and dabrafenib, binimetinib, and trametinib. The Columbus phase 3 trial has showed that encorafenib in combination with binimetinib and encorafenib monotherapy showed a favorable efficacy compared to vemurafenib. Most of the studies are done by Western literature only because melanoma in our India is not that much common. So only the literature was taken reference from Western countries. At last, the combination of surgery and systemic treatment. So, Smith et al. Did a group of patients with metastatic melanoma who underwent surgical resection with and without systemic therapy. Patient who had a systemic therapy after surgical resection showed increased survival rate. So, We have to go for metastatic melanoma, combination of surgery and systemic therapy to improve the survival rate of patient. Just surgery alone doesn't improve the survival rate of patient, leading to grave prognosis. So there's a collaboration between a surgeon and oncologist needed for a good outcome of patients with metastatic malignant melanoma of the GI tract. Thank you.
Time period between the resection, the thumb was excised and it was in 2019.
Yes, sir.
And this is 2023, 4 years.
Yes,
What
sir.
is the usual time of presentation of metastasis?
Usually it takes nearly, according to literature,
according to literature quotes, what
literature goes 52 months, so the 4 years duration only say this.
so it fits
Yes,
in?
it exactly fits the case, sir.
Okay.
Those were two separate lesions, or the gastric and the usual?
Yes, sir. Those are two separate lesions, sir. One was
Biopsy was also done?
Yes, sir. Biopsy also was done over the lesions, sir. But this fundus lesion had a bleeding manifestation, sir. Adrenal injection was done on the day of endoscopy.
Lesion says colonic involvement, small bowel you showed.
No, sir. Colonic some lesions were there, sir.
It's not any active lesion.
Yes, sir.
Quite unusual to have
Gallbladder, yes.
no, other metastatic, even liver seems to be quite clear.
Yes, sir. But gallbladder was there, and ileal loops were also involved,
it
sir.
seems to settle on the luminal organs, is it like that?
Yeah, yes, sir. It was like that. Mostly all of the gastric, duodenum, every luminal was involved, sir.
You said
Actually, it was.
ileum was also, jejunum also, there
Yeah,
was
sir.
metastasis
Yes.
noted on PET.
Yes, sir.
Any protocol to screen these patients, sir, on follow-up, these multiple melanoma patients? There are quite a few cases of gastric metastasis where we have seen. So how do you follow up and screen these patients post the initial surgery or?
The melanoma follow-up is for 10 years, not 5 years with like other malignancies. The standard recommendation, what we end up using there will be like dermatological follow-up will be every 6 months for 10 years. After 5 years, it will be once a year with the derm. And CT scans actually will be done like, not CT, usually PET will be done like 6 to 12 months for the first 2 years and then yearly for 5. After 5 years, it will be about the discussion of the physician and the patient, either to go for CT scan or a PET scan. Usually after 5 years, the insurances will not authorize for a PET scan because of the cost there. So invariably after 5 it will be a CT, and that will include chest, abdomen, pelvis, as well as an MRI of the brain because of the high propensity for the CNS mets. And nowadays for the melanoma, we try to give neoadjuvant immunotherapy and then take them for surgery. But if they have a bleeding and other scenarios, then surgery that will be followed by the immunotherapy.
Thank you, Dr. Pradeep.
Thank you, sir.
Now we call upon the next speaker regarding diagnostic dilemma of small bowel enigma. The speaker is Dr. Vimal Raj from MMC.
Good evening. This case is about a 25-year-old female. She's been symptomatic for the past 15 years. So I would like to start with the birth history. I won't take much time. She is born of a second-degree consanguineous marriage. She's the third child in his family. Full-term baby with birth weight of 2.2 kg. There's no history of any NICU admission. She was breastfed up to 2 years. Routine immunization given, attained developmental milestones which is normal for each. This is a pedigree chart showing there is no family members affected. It started in 2007 when she was 9 years old. She had tiredness, fatigability and recurrent episodes of fever which lasted for 2 to 3 days without any specific localizing signs. She was, every time she was treated by a local physician. She was treated symptomatically. She was not evaluated with any investigations. On 2009, she continued to have intermittent episodes of abdominal pain and tiredness. She noticed herself to be the shortest in the class. However, her scholastic performance was good. She consulted a city medical college in Chennai. She was diagnosed to have anemia with hemoglobin of 4 with MCU of 61. SOBT was found to be positive. Ultrasound abdomen, hemoglobin variant analysis and Meckel's diverticular imaging was done, which was found to be normal. Then she consulted a reputed pediatric hospital in Chennai. OGD was done, it showed a partial CP web, rest was normal. Colonoscopy was done, it was normal. Ileal biopsy showed only chronic idiitis. She was symptomatically treated with blood transfusion, was discharged with iron supplements. On routine screening, she was diagnosed to have Manto positive. She was started on ATT empirically, which she took for only 1 week. Then she stopped because of GI intolerance. Then she was taken to another reputed hospital in Coimbatore. Then she was diagnosed as a case of iron deficiency anemia with obscure bleed. They proceeded with enteroscopy, which showed small ulceration in mid-jejunum. Biopsy revealed non-specific inflammation with preserved villus architecture. CT angio was done. There is a 30% block in the proximal celiac artery with post-stenotic dilatation. She was proceeded with laparoscopy-assisted enteroscopy, which revealed ulceration and scarring with mild ooze in mid-jejunum. 3 cm of the segment was resected. On histopathology, which revealed leukocytoclastic type vasculitis. She was started on steroid, which she took for 6 months. Even after steroids, she continued to have symptoms. So they proceeded with capsule endoscopy, which showed narrowed segment with linear ulcer at jejunum. Capsule was retained. She was given 3 days of IV methylprednisolone, but there was no response. They proceeded with resection and anastomosis. Post-op histopathology showed foreign body granuloma. Rheumatology opinion was obtained. They did entire ANA panel, which was found to be negative. Still, they have started her on injection cyclophosphamide monthly, which she took for 6 months. Throughout the course of the disease, she had abdominal pain, she felt tiredness, she was given multiple blood transfusions. Then, since the symptoms didn't improve, she was proceeded again with anti-TTG antibodies, which was found to be negative. OGD was repeated, which showed unhealthy jejunal mucosa. This time biopsy revealed diffuse lymphoid infiltrate of duodenal mucosa, which is suspicious of mucosal lymphoma. ISC showed 90% CD3 positivity, 5 to 10% CD20 positivity. Final diagnosis was given as enteropathy associated T-cell lymphoma. Now she was referred to MMC for medical oncology opinion, where they did a slide review with PET-CT. Slide review showed there is no evidence of lymphoma. PET-CT, there was no increased SUV uptake. So the final opinion was given us to follow up the case every 3 to 6 months. They proceeded with MR enterography, which showed thickened enhancing proximal and mid-jejunal loops and lymphomatous changes. Proceeded with laparoscopic adductolysis with intra-op enteroscopy, found to have multiple strictures with ulcerations in jejunum. They went on to resect up to 45 cm of her small bowel. Biopsy specimen was sent to CMC Vellore. Gross examination, which showed multiple strictures, longest measuring 3.8 cm. There are multiple small ulcers in the mucosal aspect without involving serosal aspect. There was no creeping fat. Adjacent bowel wall was normal. Microscopic examination showed the focus of ulceration was replaced by acute inflammatory exudate. There are infiltrates of lymphocytes and plasma cells. There was no evidence of transmural inflammation, no evidence of granuloma, no dysplasia, no malignancy. Opinion was given as either ischemic or vascular etiology to be considered. Then she was evaluated at MMC. Push enteroscopy was done in 2016. Jejunal biopsy taken, again reported as inconclusive. Same session was sent to 2 different labs, reported as non-specific inflammatory changes. Bone marrow study was done, it was normal. SIBO test was done, it was negative. Anyway, she was started on prednisolone plus azathioprine, but she didn't have any significant improvement. She continues to have her abdominal pain. She continues to have a hemoglobin drop with tiredness. Then again, she consulted herself a private hospital where single balloon enteroscopy was done. Jejunal mucosa showed focal ulceration. This time histopathology shows chronic jejunitis with helminthic larva, possibly ankylostoma. She was treated with anti-helminthic. The same time, fecal calprotectin was also elevated. She was started on pentasa also, but she continues to have same symptoms. She was taken to another hospital. All the previous slides were re-examined. Vasculitis workup was done. Serum immunoglobulin level was done. Everything was normal. Blood-borne virus scan was done negative. Started again on prednisolone and azathioprine. But still, there was worsening anemia with hypoalbuminemia. So single balloon antegrade enteroscopy was done. Mild patchy erythema of jejunum noted. CBNAT and MJIT culture was done, which is negative. TPMT activity was checked, it is normal. ANCA studies was done, it is negative. MR enterography showed wall thickening in distal jejunum and proximal ileum with mildly increased mural enhancement. Fecal calprotectin was elevated. She was continued on prednisolone and azathioprine. Consulted another reputed hospital. Slide reviews of all the 2015 biopsies and 2019 biopsies was done. All the reports were inconclusive. Anyway, she was started on first dose of infliximab. After starting infliximab, she developed fever, increased abdominal pain, oral ulcers. She stopped after the first dose. She is not willing to continue further. At present, she is having complaints of abdominal pain, which is insidious onset, very umbilical, not radiating. There is no specific character, aggravated by food intake, relieved partially by analgesic. She has difficulty in doing daily activities, history of nocturnal awakening. There is no change in pattern of pain, no mass, no distension. She is having tiredness, fatigability, failure to gain weight. She is having secondary amenorrhea for past 3 years. Her ECOG performance status is 2 now. Clinical picture. She is 25 years old but weighing 76 kgs. Height is 140 centimeter. BMI comes around 13. Recent investigation showed CRP of 4, ferritin is 7, iron is 8, very low. TIBC is 102. Vitamin B12 and folic acid level was normal. Serum immunoglobulins and complement level was repeated. It is normal. Hormonal profile was done because of amenorrhea. It is normal. MRI pelvis showed hypoplastic uterus with normal ovaries. He is in regular follow-up with a gynecologist. At this stage, we had these possible differential diagnoses. These are not in specific order. We have these possible diagnoses. These are some case reports where similar history was recorded. Childhood onset anemia, hypoalbuminemia, failure to growth, which was diagnosed after 10 to 15 years of evaluation. It was diagnosed to be a cryptogenic multifocal ulcerous stenosing enteritis. There was multiple case reports. Few case reports, there is a conflict between Crohn's disease and this C-Muse. C-Muse also reflect vasculitis in many studies. A few points on C-Muse. The first case was reported on 1964. It was defined as it's a rare condition affecting the small bowel, characterized by multiple unexplained ulcerations and strictures without systemic inflammation, typically but not always in middle-aged or young patients. Occurs predominantly in ileum. Terminal ileum is usually spared. Ulcers are multiple. Small intestinal lesions never progress to cobblestone appearance. There was never progress to fissure or fistula. Ulcers are restricted to mucosa or submucosa. They never extend to proper muscular layer. Diagnostic criteria was given as unexplained small bowel strictures, superficial ulcer in mucosa and submucosa. There is a chronic ulcerative stenosis of small bowel after surgical resection. There is no signs of inflammation. Improvement after administering corticosteroids, excluding other small intestinal ulcerative disease. This improvement after steroids, it was presented in a paper Chung et al. In 2016. The response rate is approximately 25%. That too, sustained remissions for more than 1 year is not common. Surgery can resolve the symptoms in a considerable number of cases, although relapses are not rare. There are few case reports where anti-TNF drugs were given in the C-Muse. This is one such case report. Only this case, in this case report, this case was followed for only 6 months. The ultimate aim for presenting this case is, we don't know whether we are dealing with Crohn's disease or is it something new. Given this differentials and given this slide, this is more in favor of C-Muse, but we wanted to know whether we are still not in the. We wanted to know whether it is C-Muse something new or we dealing with still celiac disease. That's all. Thank you.
Thank you, Dr. Vimal. It's such a wonderful presentation. And I had a common doubt. You are telling that the event being started at around 9 years of age.
9 years.
I mean, 7 to 9 years of age. But the initial biopsy showed findings of leukocytoclastic vasculitis. Could it be, even though the vasculitic profile tends to be, all those things tends to be negative, whether if all those profiles is negative, does it mean that no rheumatological focus or any other possibility to be considered, even though the vasculitic profiles tend to be negative? Is there any possibility of rheumatological focus at around 9 years of age to consider in terms of HSP or any other presentation in which occult GI bleed will be a more common presentation at that age group?
Sir, HSP is possible, sir, but
No, my question is, even though the markers, everything is negative, is there any still possibility to consider more in favor of a vasculitic event? Because a event which has been progressing for more than 10 to 15 years without any signs of response, what is your opinion in that area?
I don't have.
Then the question is open to the day, sir. Yes, sir. Yes, sir.
A simple vasculitis because the patient should have either responded to steroids or to immunosuppressives, and even surgery the patient is not responding, it's unlikely to be vasculitis. Now I just want to know from this presenter, since I'm not very familiar with CMUs, what happens to CMUs when you operate? Does it recur?
It recurs, sir. It needs frequent surgeries.
Whether there is any strictures been associated in that?
CMUs. Yes, sir.
No, whether they have undergone any dilatation for the patient?
No, not that. No dilatations.
No
Only in jejunum we have strictures. Not other.
In case if there is any evidence of small bowel stricture, how frequently will be encountering with dilatation?
Sir, it may relapse, but no specific time was given, sir. Only CMUs, only totally 100 cases, less than 100 only reported, sir. So
What is the reason the patient not taken monoclonal antibiotics? Only because of the adverse events or financial status or all those things?
not financial, sir. After first dose infliximab, she had aggravation of symptoms. So she doesn't want to continue. Even we suggested adalimumab for that case, but she doesn't want to take.
So, nice presentation, but the diagnosis of CMUs, it's difficult to fit this particular patient in CMUs. You have any image of this enteroscopic image of ulcers? No.
Everything was done.
So what happens in CMUs, it's a circumferential short segment strictures. You know, it's stenoting, it's mentioned as stenoting. So we need to establish a short segment narrowing, and it will be multifocal. That's what, multiple sites. And even none of the histologies were very convincing. Like one time it's like something else, vasculitis, one time it's like lymphoma. So I don't think, I mean, it's, as, I mean, you said, like CMUs, no good treatment is available. You have to just give some form of immunomodulation and wait for the response. But this particular patient, it doesn't fit into CMUs. We had an opportunity to follow up some patients with CMUs, but their problem will be pain and blood loss not amounting to transfusion. They will be having, like, I mean, anemia for long rather than, so it's very difficult. I mean, unless we have a good histological evidence, it's difficult to say.
That was a very nice sequential presentation. I think he has presented it more because he wants opinion from the audience.
Yes.
I think they don't seem to be going well. What I take from this is, the learning point is that, you need a lot of misadventure here. I think once you have a surgery done, you don't go and give a capsule. I think when you've already made out that there are multiple strictures, you don't go into tests which is potentially harmful to the patient.
Yes.
So even the enteroscopy, I think Arun will say that even when you have diagnosed multiple levels of strictures by other imaging modalities, enteroscopy is probably not the option at all. You can't do that. You will land into trouble. And unfortunately for the patient, we still don't have a diagnosis. And since it looks like probably immunological mediated, I am not very well versed with CMUs, but then we think that some sort of immunotherapy would probably help this patient. That is my contention, because she's already gone through a lot of trouble, and looks like each hospital, you said reputed hospital 1, 2, 3, 4, 5, all of them seem to have probably given up on that patient. I think we need to probably see whether we can convince her to take some sort of a immunomodulator therapy, and then even prednisolone, I don't know whether it would probably help in this patient. My thoughts.
Genetic was not done.
No family history, I think, is only child. No family history. No family history.
There is no family history in this. You can't randomly.
We have many children with no family history, no consanguinity. Still, they have got genetic positive.
Okay.
We have got many children like that. I'm asking, is there any genetic basis? I'm asking.
Madam, regarding genetic basis, if you want to consider means, that's a huge amount for the genetic basis and all those things. But regarding this presentation, what genetic basis can we consider, madam, regarding this?
Because everything else negative, that's what.
Patient has had anemia since childhood.
Yes.
I think iron deficiency since 2009, I believe. Yes. Can it be celiac disease? Is it possible to be seronegative?
Sir,
we'll get a classical biopsy. Biopsy will be classical.
All the biopsies it is mentioned normal
it's not,
Windows architecture,
not
normal
celiac.
architecture only, sir. We are in the dilemma only, sir. We don't know whether to treat as Crohn's, whether to continue treatment with Crohn's or is it something else, we don't know.
Because the fecal calprotectin has been high throughout, more than 2000 and odd.
Yes, sir.
So that is also
Probably we could probably try to treat her with.
But none of the biopsies show in transmural involvement also.
Okay.
That is also.
It's a transmural because once it becomes narrowed, it is transmural.
The treatment between Crohn's and CMUs doesn't make a big difference. It's going to be steroids, immunomodulators, and probably infliximab or some other biological. But they are resistant to treatment. Whatever you do, they will persist to have problems.
Okay.
But it's really difficult to see, having serious and multiple episodes and bit more for a benign course of this CMUs.
Okay.
It's too much.
Is this a case for small bowel transplant?
No, sir.
You affect only the small bowel.
No, sir. I don't see, if I don't find any reports like that, sir.
And as of now, there is no evidence of intestinal failure being
Failure,
happened.
yes.
So we can withhold the patient before considering other line of for small bowel transplant.
Nobody has an answer.
Thank you, sir.
Thank you very much.
Thank you, sir.
Fantastic presentation.
Yeah, the next is going to be pancreatitis. So I just thought a little different. Instead of being on the chair, a little time away from the chair before I go back to the chair. So we had a small opinion poll on what is the practice pattern amongst the gastroenterologists here today. It was a little late, but I thought, okay, fine. Coming. So we'll have the exit poll results. So all of the participants, actually thank you very much for the exuberant response. So we are going to have some soft unpublished data before we have hard data from Dr. Srinandini. So the first question was how many patients of acute pancreatitis on an average you manage over here. Total responses were 34 and most of them said more than 20 per year. I think so reasonable number of pancreatitis we've been having. And quite a few had 20%, so almost 70% more than 10 per year, right? So etiology profile, again, most of them had, most common was ethanol, followed by biliary, and then idiopathic and metabolic. So I think ethanol still holds the first place in pancreatitis amongst our practice, followed by biliary. So what is the severity of acute pancreatitis in your practice? What is the next question? Again, most of them felt mild, most common was mild and then followed by moderate and then severe. Although there was some of them who had moderate more common than mild. Yeah, this is where there was a very gross shift. Scoring system used for stratification, I had just put around 5, BISAP, Modified Marshall, Ranson, Apache 2 and Glasgow. Apache 2, of course, no one uses because it's too complicated. I knew about that. Modified Glasgow, no one. But overwhelming percentage of the responses was for BISAP. So I think most of us practice BISAP here. Modified Marshall, 1 or 2 were given. Modified Marshall and Ranson. Analgesic preferred against predominantly tramadol, followed by paracetamol. Pethidine no one seems to use nowadays, and morphine, of course, no. And IV fluids, again, everyone has agreed with the fact that with the general data, going at the general literature, that ringer lactate is the most common IV fluid used. Rarely normal saline also, some of them had responded. I didn't go for the aggressive versus moderate resuscitation because it is accepted that moderate resuscitation is the way to go. So this is one another thing. Which situations you give antibiotic in acute severe pancreatitis? This is when the patient comes in, that's what I meant. So most of them agreed that patients with biliary pancreatitis, moderate and severe acute pancreatitis, they go on and give antibiotics. Some of them had responded, all patients with severe acute pancreatitis. Yeah, so there is a general, the data says that all patients with severe acute pancreatitis who are very sick will require empirical antibiotics. And of course, many of us give in biliary pancreatitis because there is some cholangitis associated most of the time. And this was the last question, average length of hospital stay in patients with severe acute pancreatitis. Most of them said patients get well and go within 2 to 4 weeks. Some of them 6 to 8 weeks. So I think most of us are doing reasonably well in managing severe acute pancreatitis. So I call upon Dr. Srinandini for the hard data.
Good evening to one and all present here. I am Dr. Srinandini from Government Keelpark Medical College. Before going to the presentation, I thank all my professors and TNISG for giving this opportunity. I am going to talk about treatment of acute pancreatitis, review of Indian literature. I am going to speak about early phase management of acute pancreatitis in early phase and late phase. Early phase is mainly talk about fluid management, pain management and nutrition, and late phase about management of pancreatic fluid collections. So diagnosis of acute pancreatitis, according to revised Atlanta classification, diagnosis of acute pancreatitis requires 2 of the following features, which is abdominal pain and laboratory value serum lipase or amylase at least 3 times greater than the upper limit of normal, and radiological characteristic features of acute pancreatitis, preferably CECT abdomen. Less commonly, we are using ultrasonography or MRI for diagnosis. Presence of 2 of the following 3 criteria is considered as acute pancreatitis. So according to pathophysiogenesis, acute pancreatitis, it is divided into 2 phases, early phase and a late phase. Early phase usually lasts for less than 1 week, and the late phase lasts for more, late phase presents after first week of presentation. This early phase, it is mainly due to the inflammatory response to the pancreatic injury. This results in release of cytokines, which causes systemic inflammatory response and leads to complications like hypotension and organ failure. So the treatment changes. Changes for early management and late complications. Grading of severity based on revised Atlanta classification, pancreatitis is graded into mild, moderately severe and severe acute pancreatitis. Mild is that is without organ failure and local or systemic complication. Moderately severe acute pancreatitis is a transient organ failure that is less than 48 hours, or a local or systemic complications without persistent organ failure. And severe acute pancreatitis is a persistent organ failure, that is, it can be a single organ failure or a multiple organ failure. How to predict severity of acute pancreatitis? Predicting severity is important because of severe acute pancreatitis is associated with high mortality. There are many scores available for predicting acute severity. In India, a study conducted in Ranchi about clinical pattern of acute pancreatitis, and this study it also compared Ranson score, BISAP score and Apache score as a predictor of severity. This study showed that mild pancreatitis compromises about 75%, and the remaining 24% compromises and the remaining 24% is formed by moderate severe acute pancreatitis and severe pancreatitis. And this study showed that all these scores are significant in predicting the severity, but this study also found that the sensitivity, all these studies has low sensitivity and high specificity, and the sensitivity ranges from 52 to 56% and specificity ranges from 88 to 90%. And this study conclude that there is no ideal predicting system for acute pancreatitis. Another study which is conducted in Asian Institute of Gastroenterology, This study studied the utility of harmless acute pancreatitis score in predicting non-severity of acute pancreatitis. And what is harmless acute pancreatitis score? It is defined as absence of rebound abdominal tenderness, serum creatinine of less than 2 milligram per deciliter, hematocrit of less than 43 for male and less than 39.6 for females at the time of admission. If the patient fulfill all these three criteria, then the patient is considered as HAP score positive. And this study showed that 90% of the patient with HAP score positivity are mild acute pancreatitis, and these studies showed that the sensitivity of HAP score is 76% and specificity of 85% in determining the mild pancreatitis. Another study which is done in Lady Hardinge Medical College, New Delhi. This study assessed the severity assessment of CT severity index and modified CT severity index, and it also assessed its correlation with CT severity grading of acute pancreatitis as per revised Atlanta classification. This study found that this modified CT severity grading has a 100% sensitivity in detecting severe acute pancreatitis, and the CT severity scoring has 97% sensitivity in predicting severity. What is the international recommendation? International Association of Pancreatology recommends 3-dimensional approach to predict outcome of acute pancreatitis. It includes host risk factors, clinical risk stratification, and monitoring response to initial therapy. Host risk factors includes age, comorbidity, and body mass index. And clinical risk stratification is mainly based on systemic inflammatory response syndrome. And response to treatment can be assessed by presence of persistent systemic inflammatory response syndrome and blood urea nitrogen levels and serum creatinine levels. Coming to treatment, treatment is divided into two parts: early phase management and late phase management. Early phase management, there is no definite treatment for acute pancreatitis. It is mainly supportive. Supportive treatment includes fluid management, pain management, and nutritional management. In that, fluid management is a cornerstone for management of acute pancreatitis. There are many controversies regarding fluid therapy, regarding volume and rate of fluid resuscitation, whether aggressive fluid resuscitation or restricted fluid resuscitation, and choice of fluid, colloid or crystalloid, and in crystalloids, RL or NS. In India, there are less studies in fluid management. So one of the study which is done in PGI Chandigarh, this study compared nasojejunal fluid resuscitation versus intravenous fluid resuscitation in patients with predicted severe acute pancreatitis. In this study, both groups were given 20 ml per kg bolus of fluid over a period of 30 minutes, followed by continuous infusion of 3 ml per kg per hour. In the intravenous group, the solution used is RL, and in the nasojejunal group, ORS is used. And the adequacy of fluid resuscitation was monitored by CVP monitoring and mean arterial pressure, and the first assessment was done after 6 to 8 hours, and if those patients who are responding to volume targets or the rate of fluid response fluid replacement is reduced to 1.5 ml per kg per hour. Those patients who are not responding to volume targets, in a IV group another bolus of 20 ml per kg RL was given, whereas in a NJ group they were excluded from the study and they are started on IV fluids according to the treatment protocol. So this study, so these two groups are compared in terms of outcome like organ failure, persistent organ failure, surgery and need for surgery and mortality. And this study found that NJ fluid resuscitation is feasible and equally effective when compared to IV fluid resuscitation in a selected group of patients. The international recommendation about fluid therapy in acute pancreatitis is a goal-directed IV fluid therapy, which is 5 to 10 ml per kg per hour, and in a ringer lactate solution is a recommended fluid of choice, and the response assessment can be done by non-invasive, invasive or a biochemical targets. Non-invasive targets are preferred, which includes heart rate, mean arterial pressure and urine output. Invasive targets include stroke volume variation, intrathoracic blood volume variations. Biochemical target is a hematocrit. Next, next management is pain management. We are using opioid and NSAIDs for pain management. In India, there is a study which is conducted in AIMS. This study compared, it's a randomized study which compared pentazocine, a opioid agonist, against diclofenac for, in managing acute severe pancreatitis. The pentazocine group received 30 mg of pentazocine intravenously Q8 thalli, and the diclofenac groups received 75 mg Q8 thalli. And the outcome was measured in terms of need for rescue medication, which is a fentanyl. And the secondary outcomes was adverse effects was also studied. And this study found that the pentazocine group has significantly lesser need for total doses of fentanyl rescue medication needed. So, and the adverse effects are comparable between two groups. So, this study concluded that pentazocine opioid, that is opioid group of drugs, are significantly better than NSAID, diclofenac, for pain relief in acute pancreatitis. Another study which is done in PGI Chandigarh, this study compared diclofenac and tramadol for acute severe pancreatitis pain management. This again, this primary outcome like pain improvement in pain was assessed by visual analog scale, and the need for rescue medication was also assessed. And this study found that there is no significant difference between diclofenac and tramadol group. So, and concluded that both diclofenac and tramadol are equally effective in controlling pain, and the side effect of profile is also comparable in both cases, in both drugs. So, coming to nutrition part, there are many studies on nutrition regarding timing of initiation and the route of administration. The current recommendation is nutrition is essential in both early phase of pancreatitis as well as in late phase of pancreatitis. AIMS study which compared nasojejunal and nasogastric group for early enteral nutrition in acute severe pancreatitis. So, in this study, a patient was given a early enteral feeding, that is after 48 to 72 hours of hospital admission, and the calorie intake was gradually increased from 250 kilocalories to 1800 kilocalories over a period of 7 days. And at the end of 7 days, patients' biochemical parameters and nutritional parameters were measured. And the outcome was compared, the outcome like recurrence of pain, need for partial parenteral nutrition, hospital stay, and mortality was compared. And this study showed that there is no significant difference between nasojejunal feeding and nasogastric feeding in case of management of acute pancreatitis. Another study which is done in PGI Chandigarh, which compared enteral feeding versus parenteral feeding. And again, this study also assessed the nutritional parameters like CRP, transferrin, albumin, and also assessed the duration of hospital stay and development of infection and intervention. And in this study, the total calorie given was 2500 to 2700 kilocalories per day, with a protein intake of 120 to 130 gram per day. And this study found that both enteral nutrition and total parenteral nutrition are significantly associated with decreased mortality and improvement in nutrition parameters. So it concluded that both enteral and parenteral nutritions are comparable in management of severe acute pancreatitis. The international recommendation on nutrition is oral feeding should be started as early as possible once the patient in mild pancreatitis, once the pain start decreasing. Early enteral feeding is preferred when compared to parenteral nutrition. Enteral nutrition can be administered either via nasojejunal tube or a nasovaginal route or a nasogastric route. Parenteral nutrition can be administered as a second line therapy if the patient is not tolerating nasojejunal feeding. According to ESPN guidelines, the recommended energy requirement is 50 to 20 kilocalories per kilogram per day, and protein requirement is 1.2 to 1.5 gram per kilogram per day. Coming to antibiotics, there is no role for prophylactic antibiotic in early phase of acute pancreatitis. Indian multicentric study which is done on antibiotic use in acute pancreatitis, which showed that despite of non-recommendation, prophylactic antibiotics are used in used frequently in managing acute pancreatitis in multiple centers in India. Coming to late phase management, the late phase management is mainly management of fluid collection and sepsis. So, according to revised Atlando classification, acute pancreatitic fluid collection is divided into interstitial pancreatitis and necrotizing pancreatitis. In interstitial pancreatitis, the collection of less than 4 weeks is termed as acute pancreatic collection. If it after 4 weeks, once there is a formation of a wall, well-defined wall, then it is called pseudocyst. In an acute necrotizing pancreatitis, less than 4 weeks, it is called acute necrotic collection. After 4 weeks, it progresses to develop a vault of necrosis. A study which is conducted in PGI Chandigarh, which studied the outcome of acute pancreatic and peripancreatic collection in patients with acute pancreatitis. This study showed that most of the patients with acute pancreatitis developed necrotizing pancreatitis. That is, 81% of patients developed necrotizing pancreatitis, and in this 81% of patients with necrotizing pancreatitis, 93% of the patient developed acute necrotic collection. In the acute necrotic collections, it is associated with mortality of 16%, and half of the acute necrotic collections progress to develop a vault of necrosis. So, this study concluded that patients with severe acute pancreatitis and delayed hospitalization more often develop acute collection. Pancreatic pseudocyst formation is very rare in acute interstitial pancreatitis. Majority of patients with necrotizing pancreatitis will develop acute necrotic collection. In that, more than half of the patient will develop vault of necrosis. Delay in hospitalization and higher baseline necrosis score predict the need for intervention. This picture shows, the first picture shows the presence of pancreatic necrosis, second picture shows the acute necrotic collection, and the third picture shows vault of necrosis with a definite wall. Another study which is conducted in AIMS, this study studied the association of extent and infection of pancreatic necrosis with organ failure and death in acute necrotizing pancreatitis. And this study found that patients with more than 50% of necrosis are associated with increased risk for development of organ failure and mortality. And patient with infected pancreatitis, the mortality is 50%. So, this study concluded that the extent of necrosis and infected pancreatic necrosis were associated with significantly associated with the development of organ failure, and the infected pancreatic necrosis was a most significant predictor of mortality. Coming to indications of intervention in necrotizing pancreatitis, the indication for intervention is infected pancreatitis. One is a documented infected pancreatitis. Another one is a clinical suspicion with ongoing organ failure is another indication for intervention in necrotizing pancreatitis. In case of sterile necrotizing pancreatitis, the indications are when the pancreatic fluid collection causes organ compressions like gastric outlet obstruction, bile duct obstruction, or complications like abdominal compartment syndrome or disconnected pancreatic duct. There are various approaches for drainage, which include endoscopic drainage, percutaneous drainage with radiological guidance, and surgical drainage, open surgery or video assisted retroperitoneal drainage. And another approach is next one is a step up approach, in which initial drainage, which is followed by necrosectomy in those cases where the patient having worsening organ failure or persistent organ failure. So, the AIM study, which compared the it's a retrospective study which compared primary conservative treatment versus surgery in patients with acute infected pancreatic necrosis. And this study showed that during a past period of 10 years, the patient who received primary conservative treatment had significantly higher survival rate than those who received surgery. Another study which is done in PGI Chandigarh, which compared endoscopic drainage versus percutaneous drainage for management of management of infected wall-off necrosis. And this study showed that endoscopic drainage group had a significantly higher rate of technical and clinical success, and for higher, the faster resolution of organ failure when compared to percutaneous drainage. And this study also suggested that percutaneous drainage should be avoided in walled-off necrosis with more than 40% of solid components. This picture shows direct endoscopic necrosectomy, and the second picture shows percutaneous catheter drainage. Another study which is done by Pramod Kumar Garg in AIIMS, this study compared endoscopic versus laparoscopic drainage of pseudocyst and walled-off necrosis in acute pancreatitis. So, in this study, the patient was randomized into laparoscopic group and endoscopic group. This endoscopic drainage, they comprised of initial percutaneous initial peroral transluminal cystogastrostomy, which is followed by a step-up procedure with endoscopic lavage and necrosectomy for a patient with infected collection, and the laparoscopic group underwent surgical laparoscopic cystogastrostomy with drainage, lavage and necrosectomy in a single setting. So this study, the primary outcome were compared between these two groups, and this study showed that endoscopic and laparoscopic techniques have similar efficacy for internal drainage of pancreatic collection, and the choice of procedure should be depend on the availability of expertise. So the international recommendation is initial image-guided percutaneous drainage or endoscopic drainage, followed if necessary by endoscopic or surgical necrosectomy. Regarding timing, the recommended timing is after 4 weeks to allow the collection to become walled off. But there are certain indications for early intervention, which includes organ compression, abdominal compartment syndrome, or disconnected pancreatic duct. So one study which is done, a study by Surinder Singh Rana in PGI Chandigarh, this study compared endoscopic versus percutaneous drainage in symptomatic pancreatic necrosis less than 4 weeks of duration. This study showed that the endoscopic drainage group is associated with shorter duration for resolution and infrequent need for salvage surgery when compared to percutaneous group, and the fistula formation is more common with percutaneous group. Coming to stents, endoscopic drainage can be done using plastic stents or a lumen opposing metal stents. A study in PGI Chandigarh which compared plastic versus lumen opposing metal stents for drainage, and this study showed that there is no difference between the plastic stent and metal stent in either mortality or complications, but this study found that the time taken to resolution was significantly shorter in lumen opposing metal stent when compared to plastic stent. This picture shows a plastic stent with nasocystic catheter, and then second picture shows a lumen opposing metal stent. Coming to management of acute biliary pancreatitis, regarding indication for ERCP, there is no studies, studies for indication of ERCP, no Indian studies for indication of ERCP. The IAP recommendation is urgent ERCP of less than 24 hours is required in patient with acute cholangitis. And regarding optimal timing for ERCP in the absence of cholangitis, there is no evidence. And coming to the timing of cholecystectomy, an Indian study which is done in Nagpur, which compared early versus late laparoscopic cholecystectomy for acute biliary pancreatitis. This study showed that early laparoscopic cholecystectomy is associated with less intraoperative and postoperative complication when compared to late laparoscopic cholecystectomy. And the IAP recommendation for cholecystectomy in biliary pancreatitis is cholecystectomy during index admission, and interval cholecystectomy is associated with increased risk for readmission for recurrent biliary events. So the take home message is predictors. Regarding predictors, there is no ideal predictor for acute severe pancreatitis, and the fluid management is mainly goal directed, and pain management, either opiates or NSAIDs can be used. Early enteral nutrition is essential for both early and late phase of pancreatitis. Enteral nutrition is preferred than parenteral nutrition. Antibiotics, there is no role for prophylactic antibiotics in early phase. Regarding fluid collection, the intervention is needed only for infected necrotic pancreatitis, preferably after 4 weeks, with some exceptions, and conservative treatment is preferred over surgery. In conservative treatment, endoscopy is preferred over percutaneous drainage. In some cases, step-up approach is preferred. Thank you.
Thank you, Dr. Srinandani. It was very well compiled. It categorized it properly and then compiled it and had some papers on each. Just to start off the discussion, a few points. One thing I thought which was missing is etiology, any data on etiology.
Sure.
There are papers.
No. The common scenario will be 30 to 40% for 30 to 40% for biliary pancreatitis, and around 25 to 30 for this one alcohol-induced pancreatitis, and 25 will be for idiopathic, and less than 5 for ERCP. That's what the data has been compiled, but there is no proper such study been happening in India. And in CMC Vello, they have been tried to study with recurrent acute pancreatitis, not per se for the etiology for acute pancreatitis.
There have been some papers which I was going through.
Yes, sir.
There are studies on at least retrospective data, and these were the etiologies. And again, ethanol is the most common.
Ethanol, yes, sir.
Biliary. And then you have hypertriglyceridemia and hypercalcemia, those metabolic factors. Then you have idiopathic. And then I think post-ERCP, it's a totally different ballgame. Yes, doesn't come into this. So there are, and that's what most of us agreed to us, like what we felt is ethanol is most common. So that's one thing. And then as far as this fluid resuscitation is concerned, you said NJ versus IV fluids. Something, it was a little surprising, that study on NJ feed in early phase versus IV fluids, giving such amount of fluid through the NJ in an acute phase when there's a lot of ileus, was something little, I was just wondering how many of us will be really willing to do that?
Yes, sir. It was done in a patient with predicted severe acute pancreatitis, with Ranson score of more than 2 were taken as a study group, sir. Not in a severe acute pancreatitis. A predicted severe acute pancreatitis with Ranson score of more than 2 were taken as a study group.
So again, so it's when someone is predicted to have a severe acute pancreatitis, the likelihood that they have ileus and other things is pretty high.
Yes, sir.
So it's just an observation. Any other points? No. This is acute fluid resuscitation with fluids, not the refeeding. That's what refeeding is clear. It's NG versus NJ. Either of the two is accepted. It's agreed that both are equal. That's in the later refeeding phase. And when it came to the studies on pain management, so pentazocin was found to be much better than diclofenac. And one study which said tramadol was equivalent to diclofenac. Now again, diclofenac, although they had studied in that, most of us will be wary to use diclofenac in acute pancreatitis because there's already acute kidney injury, so many other things which we don't. So I think any difference of opinion?
No, not on this one. See, madam, I am referring to this what's called harmless acute pancreatitis score.
Yes, sir.
One of the criteria is rebound tenderness.
Yes, sir.
Of course, I am very familiar with rebound tenderness, acute appendicitis, which is a matter of 24 to 48 hours. But how are you going to measure this rebound tenderness pancreatitis? And then, see, generally a scoring system must have measurable parameters. Is rebound tenderness a measurable? When will you do this rebound tenderness? Once a day? How many days will you do? So I find it little disturbing that this was used as a criterion.
So that actually they have been considered as harmless acute pancreatitis. There is no specific entity being mentioned in that, sir.
No, in fact, it is not a very patient-friendly procedure. How many times are you going to poke the abdomen? Already the guy is in severe pain.
So true, it's quite a subjective criteria, but the purpose of this HAP score was to categorize the patients on who actually require a ICU admission or based on assessing the severity initially. So that was the point of the HAP score.
This is done on admission to
Categorize them.
mild and severe. If it is mild, it doesn't go into the ICU category. If it's mild, it is probably managed at the ward. It is one time, not every time.
So again, the rescue analgesia will be fentanyl. So how frequently will be used in that?
Fentanyl.
You probably assess it for
Yes.
that is bedside.
I think quite a lot of us use fentanyl also. I think probably I didn't use it in my list, but fentanyl is quite commonly used. Fentanyl patches we use. It's a very good analgesia actually.
As of now, they didn't mention about anything, sir. But they have made it a trial with buprenorphine, morphine, and all those things. But tramadol and all those things they mentioned. But dexmedetomidine will not be mentioned properly.
And NSAIDs, I don't think any one of us will really do it.
No.
NSAIDs, anyone?
No.
So one is risk, another is AKI.
Okay.
Exactly.
One point. One observation I like to make is a fantastic presentation, but studies were done in Delhi, Chandigarh, Nagpur. I don't know whether our association will take up CMC Vellore, one study, but multiple studies. We see only Pramod Garg, Raj Sharma, etc. Some Indian Tamil Nadu names are, some names should have been there for acute, because we are seeing more acute pancreatitis. I am seeing more of acute pancreatitis after the corona period. After COVID, we are having increased incidence of pancreatitis. How far is others' response? I like to know. And we are nowhere near the goal. Yes, we are started from the goal post. We are still not covered the goal post. Still the same oral, the restricted correction. Are we anywhere near the treatment? No. In spite of so much of treatment, now that the pancreatitis is more dangerous than the liver, that is being proved once again. And severe pancreatitis mortality is still poor. Whether it's COVID endoscopies and surgical method, they have a study done in Stanley is more famous for severe pancreatic necrosis. They have a retroperitoneal approach. The retroperitoneal scope they do. So anybody from Stanley surgical gastroenterology, they will be able to tell the points mentioned. But a good amount of collection of studies is done in Stanley SG unit.
And next, coming to the points on nutrition, there's a study which said enteral equivalent to parenteral nutrition, otherwise parenteral equivalent to enteral nutrition in all profile. So I think what should run into is, as far as possible, going for enteral nutrition. Whenever enteral is totally not possible, it's only then we resort to parenteral nutrition, because it has its own set of complications and issues along with that. Okay, and most of the patients who require parenteral nutrition are extremely sick, or they have undergone multiple surgeries for complications, right? And empirical antibiotic in pancreatitis, severe acute pancreatitis patient is extremely sick. There is a role for empiric antibiotics, right? Okay. Most of us use carbapenems. Right? Yeah. So, any other points for discussion from the ground? We'll stop off with that after that.
Do you have mention of elemental or semi-elemental diets? Is given in textbooks. How far is very costly? Elemental or semi-elemental diets? In India, are you using elemental or semi-elemental diets?
Not very common.
Elemental and semi-elemental diets they have been trying, sir. But even immunonutrition like glutamine base and probiotics, all those things being tried, sir. But nothing proven to be useful, sir, as of now. Yes.
Yeah,
I have one common doubt, sir, before concluding. And regarding this acute pancreatitis, once a patient gets infected, even in that scenario, what various aims and PGA protocol that we mentioned, it's better to go in initial phase with conservative management, even at the duration of around 4 weeks. What is your opinion in that, sir, when you're thinking? Initially, start with conservative, and then if it is not responding, then we can go for intervention necroscopy procedures and all. So, how long we can wait for, even at the duration of 4 weeks, to start with conservative, even if the patient is going for infected necrosis?
My take is the patient requires an intervention.
The guidelines
Exactly.
It could be 4 weeks, it could be 6 weeks. Just because a pseudocyst is there, you don't go and drain unless it is causing a problem. Like it is probably obstructing the digestion organs or something like that. If the pseudocyst is infected, you have evidence that on imaging there are debris, there is fever, there are raised inflammatory markers, then you probably go and intervene. But having a fluid collection, there are clear indications when to intervene. I think it could be even less than 4 weeks, you may have to intervene if the patient has got evidence of sepsis. That's the take.
Thank you. I think it's been a good, very good presentation. I think you compiled it really well.
Thank you, sir.
Well done. Thank you very much for the data. Thanks a lot. Thanks for the interactions. Thank my co-chairs. Proceed to the next session.
So I think, again, we'll take this opportunity to congratulate. I think a few of our esteemed colleagues have been awarded Economic Times Award. Unfortunately, none of them here, Dr. Ubal, Dr. R. Ravi and Dr. Joy. I think it's a matter of great happiness that few of us have been recognized and have been given these awards. And I think also on the government side, I think quite a few of Dr. Cheli and Dr. Muthukumar and Dr. Alzaran have been promoted as associate, and I think many more will be promoted as professors all across. Going to the multi-center study, I think there's one ongoing multi-centric study that's on Plex. Hopefully, we'll be having something more in the months to come. Some new initiatives that we have been attempting is to form some special interest groups. As to begin with, I think we had an initial discussion on the endoscopic ultrasound related special interest groups, and Dr. Sudipta from CMC has agreed to take an initiative to initiate a study. That the focus of study will be on cystic lesions of pancreas. So probably it will be like a registry, a multi-center registry of patients presenting with cystic lesions in the pancreas across Tamil Nadu. The study protocol is being prepared. It will be sent to all of you for inputs and probably an expression of interest to be part of the study. So this could just be one aspect, like an endoscopic ultrasound on a special area like a cystic lesion or something. But I would be happy to have some more people who would be interested to take a lead in looking at either some topics in the liver, IBD, or just now, as Sarah said, on pancreatitis, something where our society can take a lead, start off with some studies, a multi-center study where we can, maybe a registry, it may not be a earth-shattering one, but at least it will be good to have something running side by side. So you can, probably we'll be communicating to you more on these things a little later. So other initiative that we wanted to start off was, since most of our monthly meetings, it's restricted to postgraduates who are presenting from the city medical colleges. But of late, we have had a lot of DNB and DM courses running across Tamil Nadu. Probably we are possibly contributing to most of the DM and DNB medical gastroenterology training across India. So we have centers in Coimbatore, Madurai, Thoothukudi, Tirunelveli, Salem, and I think CMC Vellore, Jipmer, Pondicherry. I think quite a few centers outside of Chennai are also having very good ongoing academic courses. So in order to include those postgraduates to give a platform for them to present as well, what we propose is to have an online CME, which will be in addition to the monthly CME that we are conducting now here. That probably will be held once in 3 months to begin with, which will be for a period of about 1 hour, where we can, it will be dedicated to one center. Let us say this time around probably we'll start up with CMC Vellore, in Vellore, and subsequently in 3 months later we can go to probably Coimbatore or somewhere, where the postgraduates, where the host center will take care of the first half of the program, where it will be for about 30 minutes, where they can have 2 or 3 postgraduates who can present the cases. And the second half will be about lectures by some eminent faculty, probably national or international, who can do it as an online. So in that way, probably we'll have some involvement from postgraduates across Tamil Nadu, as well as we also have some involvement from centers across Tamil Nadu, rather than being limited to just Chennai alone. So this could be just an online Zoom link through which we can be circulated to all the members. Probably it will be for probably on a working day in the evening. That we can always work out. And initially, I think Dr. Epan from his side has accepted to take up the first case presentation somewhere in the first or second week of August. We'll communicate to you the date and the link. We'll share the link also. Hopefully this program will benefit more postgraduates across Tamil Nadu and will add on to the academic initiative. Last month we discussed that probably we'll put up the list of publications by our own members, because quite often we don't know what is happening behind our own back. I've been sending out links and a Google form. I thank all the members who have responded to it, though it's looking very small here. We'll be putting up into the website, in our own website. We had about 17 or 18 members who have responded. It's a mix of, nice to see that in the last 6 months, we have had some 18 odd publications. I'm pretty sure there are more, possibly which has not been uploaded. It's still open. They can upload it till 31st of July so that we can compile it and put it up into our website so that we know what is happening in our own state. And right now, about 18 publications. Some are book chapters, some are case reports, some are original articles, some are editorials. It's nice to know what is happening. So I would request all members to please fill up the form. It's a Google form. It hardly takes 2 minutes to fill it up and send it to us so that we can compile it and put it up in our website. And then that will be good for us to look back and see what's happening. So this gives us a baseline. So probably next year we can see how we move forward, whether we are achieving more publications later on. The other possible initiative that we were contemplating is to have some educational content for the postgraduates on the Tamil Nadu ISG website, which is kind of still being very redundantly used. We don't use it much. Just like what we use in NEJM images, probably I'll request people with some interesting case snippets to put it up as some images. It could be clinical, it could be radiological, it could be from the pathology. It could be a small short write-up regarding that image that you want to give, and then a multiple choice kind of a question where you can attempt, and a subsequent write-up about the correct answer. So if this comes up, probably we can, depending on the response, probably we can have it every 1 month or every fortnightly. We can put it up on the website and send a link to all the members. So it will generate some kind of interest, ongoing interest among the activities. And also possibly we'll make an attempt to see with a lot of interest on the postgraduates who who would like to know more about the endoscopic instruments or even the manometry and other instruments that's coming up. I think we'll send out some request letters to all the endoscopic faculty who can probably contribute a short PowerPoint presentation for 10 minutes, some 10 slides regarding these each instruments, which can again be uploaded onto our website for people to use it. So probably we'll be working on it in the next few months. Let's see how that goes. Coming to the forthcoming meetings, midterm ISG, Tamil Nadu ISG will be on 23rd and 24th of September at Pondicherry. Venue will be at JIPMER. They are working out the logistics and probably in the academic content as well. We will be communicating to you shortly. The annual ISG meeting, the national body meeting, will be from 21st to 24th of December in Bangalore. And our annual body meeting, the Tamil Nadu ISG body meeting, will be in the second week of February at Madurai. So please mark the dates and keep it free for you to attend. Again, this time also I request you, for ease of uploading the attendance, people who have attended, we place some QR codes on your table which you can scan, and please fill out the Google form. It requires less than a minute. It asks you for 4 things: Tamil Nadu Medical Council registration number, your full name, email ID and your phone number, so that it's easy for us to upload this list to the Tamil Nadu Medical Council website for us to gain those CME points. And this time around, for the CME, before I hand it over to the chairpersons, what we have attempted is to have some audience poll so that it generates some interest rather than having a lecture. So this time around, what you will get, as the part of the lecture, they will have some questions which will come up. So, and there will be a QR code. I think just try if you can use your QR code scanner from your mobile. If you can log on, if you can scan this, you will go on to a site which will give you the question, just like this. This is just a trial run for that. And you'll have a timer which will give you like for 20 seconds or so, in which you can choose what you want to choose as the answer for your question that is posted on it. So just try this. If it helps, all of you can just scan this, see if it works. So it will be much more interactive. So another 5 seconds more. Fantastic. So let me see. So only 4 of you have attempted. I don't know why. There are about 40 of us inside. So I think it will be good to have some more interactions. I'll just go back. Let me see if I can play it again. Only 4 of us. So you even puts up who has tried. Anyway, so I mean, there is I've specifically requested all our the 2 eminent speakers to put up some audience poll questions so that it will be interactive. So with that, I request the chairpersons for the CME program, Professor Rajnikant and Professor Tai Manovan, to take over the stage and conduct the proceedings, please.
Good evening. We are in for a very interesting CME. See, gastrointestinal tract, as we all know, is a seat of a lot of malignancies, starting from esophagus, stomach, large intestine, liver, gallbladder, and pancreas. The role of a medical gastroenterologist like me and Tayu stops once we diagnose. See, once I do an endoscopy and find a gastric cancer or a colonoscopy, there is nothing much we can do. So we'll have to either hand it over to a surgeon, gastroenterology surgeon or oncologist surgeon, or to an oncologist, medical or radiologist. So now, earlier days, it was a polytherapy, but now the oncologists are doing what is called target therapy. That's what we are going to hear. Regarding target therapy, it's not enough if you have a gun. You have to have aim at the target properly. Just a joke. See, we all see in our movies, one side there will be 10 villains, and the other side there's hero. 10 villains will be shooting with machine guns at 100 per second, but nothing will touch the hero. But hero will shoot once, and all the 10 will die. So that is what is target therapy. So we have first speaker, a well-known familiar figure, Dr. Shankar Srinivasan. He has been here in our forum many times. He is a medical oncologist working at a consultant in Apollo hospitals. He has had a widespread training in United States, and he is a seasoned oncologist. Dr. Shankar Srinivasan, please.
Okay, I think, thanks for the wonderful words. When I first thought like I will talk about the targeted treatments in GA cancer, Pyramid told me like, hey, we do the scope, we do the biopsy, and that's it. We don't really talk about anything else. Send it to the surgeon or a medical oncologist. So keep the talk also in such a way that what we need to know, don't get into the details. So if I am kind of saying some things beyond, just stop me. Don't, because I don't think a lot of things are actually necessary also for everybody. But I'll try to give an idea like so that you also know like, I mean, what is being done. Like myself, I kind of learned a lot with pancreatitis today, which I'm pretty sure like I learned maybe like 30 years ago. But that was very helpful. At least now I can, next time when I see a patient with pancreatitis, I can tell them, oh, did they do this, did they do that? At least that is helpful. So without much, I will go ahead with the slides. This is from my Professor John Marshall, so it's a courtesy of his slide. So what a difference this decade has made. Initially, we all thought cancer was clonal. Now we know that that's no longer the case, it is polyclonal. Initially, we thought, okay, specific therapy for primary cancer, now it's like molecular-based therapies. And there's a group of people who said immune therapies will never work 15 years ago. And now it is like they are miraculous. Oh, wonderful. Gene testing, do it for some people, but don't do it for everybody. Now pretty much everybody gets testing done. Randomized phase 3 trials was the name of the game. Like unless you have a randomized trial here and there, nothing is going to be approved. But nowadays, like single arm trial, 20 patients, drug will get approved. We will come to that later in this. Microbiome is smelly and disgusting. As Marshall used to say, the easiest way of getting the probiotic is whenever you go in a mall on an escalator, just keep your hand from the bottom to the top. Once you reach the top, just lick it. And then when you come down, use the other hand, and you are done. You got your probiotics and you got your microbiome. And he does practice it though. So, cancer treatment is expensive in 2010. It is damn expensive now. We used to love our jobs. And actually, in internal medicine in US, I think highest burnout and suicide is in medical oncology, not in other medical specialties. So this is one thing about tumor heterogeneity. That's where we call it like cancer is polyclonal. We all thought like all the cancer cells are pretty similar, we can target it. So this is a study, actually, not a study, actually a single case in 2018 from a renal cell cancer. They took the tumor, and once it was resected, they just did a biopsy on 4 different angles, like northwest, south, and east. And they came up with 4 different gene profiles. So that tells you that it is polyclonal. It is never going to be like why our single therapy is never ever working. So that's the way it goes. And after you can get the tumor sequencing, I think Anil is going to talk a lot about the molecular profiling. I won't get to the details of it. The circulating tumor DNA profiling is something that we use in most of the patients. Like 5 years ago, we ended up doing like tissue, and then we did the next generation sequencing. And nowadays we do the, if we don't have the tissue, we call it like tissue is the issue, let us send the blood. But now what has happened is you do both. Right now the name of the game is send the tissue as well as the blood, pick out whichever shows you the good result, and then aim towards it. And if you really look at our DNA approaches, what we do in next generation sequencing, whole genome is being done, whole exome and targeted panels. It used to cost $20,000 to $25,000 before. Now the whole genome sequencing in US is done at $2,000. Whole exome sequencing is somewhere about like $1,500, or not even $1,500, somewhere about $700. If you want a targeted panel, it's about $200. Actually, in India, it costs about 20,000 rupees to do a targeted panel. Whereas you can get the targeted panel in US for $200 is the cost. You can get it done for $100, which is probably cheaper than what we do here sometimes. And we don't just stop at DNA, we also do the RNA. This is actually a study from Memorial Sloan Kettering. Essentially, like by just doing the DNA, we miss out almost like 15% of the time we end up missing the targeted fusions or deletions. So now we do the RNA also along with the DNA. So the best sample that what we do, a biopsy is always better. We have adequate tissue if we have, or blood. Blood, the advantage is you can do serial things. Nobody is going to agree for a serial biopsies in a patient, like I want to find out the change in the character of the tumor. So here at least the blood, we will be able to do those things. Okay. I think I have to wait for 2 seconds, 5 seconds. That's good, can go. I thought this will be something which will maybe, I thought it will be easier for all our medical gastroenterologists. 42-year-old with adeno-CAG junction with lymphadenopathy. He received chemotherapy and radiation. That was followed by surgery, typical cross protocol, chemo-RT, and then subsequently went for surgery. Patient does have residual disease after the surgery. This is something we do see like fairly commonly, like 25 to, or more than like 40 to 50% of the time. So what do we do here? Do we just do observation or give 2 cycles of chemotherapy, or we do like, usually in cross trial it's only about 45 gray, so you want to complete the radiation, or do you want to give immunotherapy with either nivolumab or tezolizumab? It's not a fair question, let me be very clear. I don't think people really have to answer these questions. I thought I'll give you some input about where we are. The answer here is like immunotherapy with nivolumab. In the past, at least like 5 years, 4 years ago, we said like, okay, chemotherapy, radiation, cross trial, surgery done, you have residual disease, go home. If you don't have residual disease, good for you. We will come and see us a few months later. So what we have now is, for the early stage GE junction cancer, For a localized either adeno or squamous cell, trimodality therapy was the standard of care. Neoadjuvant chemotherapy and radiation followed by surgery. Most of them are resistant to therapy, and you will see like residual cancer being present. And that determines the prognosis. The Checkmate 577 was one of the standard trials presented in NEJM with adjuvant nivolumab for stage 2 and 3, both GE junction and esophageal cancers. Nivolumab versus placebo. It was given for about 1 year. It included both adeno as well as squamous pathologies. So essentially, if you look at like the disease-free survival with placebo versus nivolumab, there was a significant almost doubling of the time with the nivolumab compared to placebo. And if you really look at the overall survival, that was also significantly better with the nivolumab based on the 2023 update in the ASCO session. And it was significant for both adeno and squamous cell, but more common in squamous cell. Because squamous cells have more, if you call it like there's a lot of mitosis, and you have a lot of MSI and PD-L1 expression in squamous cell compared to adenos. So that is why you see more responses with the squamous cell. Let me go to this one. This is something maybe easier. 53-year-old with a dysphagia. And the workup shows like GE junction adenocarcinoma. 2 nodes were there on the metastatic workup with the PET and everything. Peritoneoscopy or laparoscopy was negative, cytology was negative, so no peritoneal mets, no disease. Additional studies were done, MSS as well as HER2 neu was 3+. So here the standard will be like, okay, HER2 is positive. All of us were thinking that probably the trastuzumab should be used along with chemotherapies and things like that, as like what we see in breast cancer. So what are all the options here? Standard chemotherapy and radiation followed by surgery, or standard chemotherapy with trastuzumab with radiation followed by surgery. So this is what the responses have been. I'll just give some idea then before I come to this answer though. HER2 expression is fairly less common, or not less common, relatively less in GI cancers, especially if you look at the stomach and GE junction. The expression is not that great as like breast cancer. So that is one thing that we need to know about. And if it is an intestinal type, it is slightly better. So this was the trial actually done by the radiation therapy oncology group with chemoradiation followed by surgery, or chemoradiation with trastuzumab followed by surgery. If you really look at it here, the curves are actually superimposable. I mean, you won't know like which one is what. So adding trastuzumab along with the chemoradiation really does not help in improving the survival. So in the early stage GE junction cancer or esophageal cancer with adenocarcinoma, we do not use trastuzumab. But contrary to what our expectations are or the perceptions are, that will work. So that is why I think randomized trials and other trials are necessary. Okay. Think. Oops, sorry. This same patient did extremely well for a couple of years. Abdominal pain and CT scan shows multiple liver lesions. The biopsy shows adenocarcinoma. HER2 neu is still 3+. Appropriate treatment in this setting, either chemotherapy alone or chemotherapy and trastuzumab, then chemotherapy with trastuzumab and pembrolizumab, chemo with dual HER2 blocker. Okay, I'll come over here. Here, I think the thought process will be like there are 2 different answers that you can use. Chemotherapy with trastuzumab, chemotherapy with pembrolizumab. Okay, got it. Good. I think everybody got it correct though. The reason for this is mainly because of what we have at this time. To give us some idea about the HER2/neu, I think everybody know about HER2/neu in medical gastroenterology as well as in other major specialties. Trastuzumab was approved first line in metastatic setting, but not in adjuvant setting and not in neoadjuvant setting in GE junction cancers. So people started using the second generation and third generation and then dual blockade also with pertuzumab and trastuzumab. None of these things have proven to be very effective. Trastuzumab is somewhat effective, which is also not a great. Breast cancer will be slightly a better curve compared to the GE junction. So keynote. Keynote is something that all the pembrolizumab trials were called keynote trials on the immunotherapy, and all the nivolumab trials were all called checkmate trials. So you have all the way starting from 100 to 800, because they actually did a pretty good job of getting all the malignancies, go on with chemo, go on with immuno, and then things like that. So this trial essentially showed, like, if you add the pembrolizumab to the trastuzumab, your response rates were significantly higher. Almost like 75% of the patients responded, which we don't see in metastatic or advanced GE junction cancers, compared to the trastuzumab, which was about 50%. And this was the initial update based on the 2021, just on the response rates. The FDA approved the pembrolizumab and trastuzumab combination. And then subsequently, what has happened on the 2023 update in the ASCO GA chapter was the overall survival is significant, trending about like more than 11% difference between the combination versus trastuzumab. So that seems to be the now state of the art for HER2 positive GE junction cancers. And this is one thing that we all, I think, probably Dr. Anil is going to talk about this, how to test it and what all the patients, or who are all the patients where we will ask for HER2/neu. Pretty much all the patients with gastric or esophageal or GE junction cancers, we will do the HER2/neu testing. And then for the colon, I think once again we will do it unless they have the RAS mutation. I'll skip the pancreas and biliary tract. We're not going to talk about it at this time. Then coming to the immunotherapy, which I think is part of the deal here. Where are we with the advanced cancers with immunotherapy in upper GA cancers? So we have like multiple trials, once again, keynote with the pembrolizumab. Essentially what we know now is, if the PD-L1 score is like more than 10%, pembrolizumab along with chemotherapy will improve your overall survival, not only in squamous cell but also in adenocarcinomas. So the approval for pembrolizumab with chemotherapy came in for anybody with a PD-L1 of more than 10%. So anyone with metastatic or recurrent GE junction or esophageal or stomach carcinomas, we will ask for PD-L1 testing. So the competitor, which is the nivolumab, the checkmate, again nivo plus chemotherapy in advanced, not only in squamous, checkmate 649 was adenocarcinoma. When they look at it, more than 1% with the PD-L1, there was an improvement in survival overall, as well as PFS also was high. The nivolumab, what they did was, they were actually fairly clever in the way that they did the trial. They included all comers, whether it's PD-L1 was 1% or 5% or 50%, but bulk of the patients were like more than 25%. But when you apply for the approval for the FDA, you got to send all the data. You cannot do the subset analysis once you do the trial. So their philosophy was, let me include everybody, but make sure I have more patients with 25% and 50%. I'll also have 10% of patients with 1% positivity. But the overall trial, we know that it's going to be better. So it was better. So if you look at the overall, so 1% or 2% will also work, but in reality it does not. But the approval has to be given for the whole trial only. They cannot do the piecemeal approvals. So now the nivolumab is for anybody with PD-L1 more than 1%, they will get the nivolumab. But we also know that those who are less than 10% really don't respond to the nivolumab. But nobody is going to fault you if you don't give it. But somebody might fault you if you don't offer it. So that is one thing that we need to look at with these trials. And then nivolumab is ipilimumab, that's a double combo. People do use it, but most of the time the side effects are so high that people don't use it that much. So the simplified form of treatment for advanced cancers will be like, if they are HER2 negative, chemotherapy, which could be a 5FU and platinum, like cisplatin, along with nivolumab, if the CPS is like more than 5. If it's esophageal and GE junction, either it could be like either fluoropyrimidine and platinum, which could be oxaliplatin and capecitabine, K-Pox or Folfox, which we use along with nivolumab or along with pembrolizumab. If they are like HER2 positive, we will say like trastuzumab and pembrolizumab along with the K-Pox or Folfox. Or if they are esophageal GE junction, once again the same. So now it is pretty simplified for metastatic GE junction or stomach cancers. HER2 positive or HER2 negative, PD-L1 positive or PD-L1 negative. You add the immunotherapy and you add the trastuzumab. So this is the most simplistic form of treating the GE junction cancers in advance. So essentially that's the same scenario here. So what are all the testing that you would want to know as a medical gastroenterologist here? Do ask for HER2 amplification, do ask for MSI, ask for PD-L1. We have these things NTRK, but if there's enough tissue, go for NGS testing. Now you can do the NGS testing for about 15,000 rupees in India. I think bulk of the labs will do your about 52 gene testing, which will give you enough details for it. 15,000 rupees, and the turnaround time is close to 2 weeks. So within 2 weeks, you will get most of your results. And then you can decide on what to do. And whom will you do it? Pretty much for everybody with the newly diagnosed patients. The newer thing on the GE junction cancer is the Claudin 18.2. That is the new kid on the block. And in US now, we will do the Claudin 18.2 positive, for the IHC staining. If they are positive, we do have a zolbetuximab. It is still not yet approved, but the response rates are somewhere about 70 to 75% if the Claudin 18.2 is positive. So hopefully, I think this will become, in another 2 years, I think we should have these medications available for use also. Switching the gears, colorectal cancers, early stage. Stage 2 and 3. I think this is something all of us do talk about it. Stage 2, cured by surgery, bulk of them. Not cured by surgery, but 5FU will cure you. And then not cured by surgery, but 5FU and oxaliplatin will cure you. You do the surgery and you give the chemotherapy, nothing is going to cure you. Majority of them are here, and some of them are here. Very minimal patients are here. So if you look at stage 2, almost like 80% will be cured by surgery alone. Maybe about another 5 to 6% we will get the chemotherapy or so. And another 10% are probably not going to respond to anything, they are going to relapse. The question is, who is going to get the chemotherapy and who is not going to get the chemotherapy? So if I think I need to cure all of them, I need to give treatment for all the 100 patients to give a benefit of probably about 8%. That means this 10 is not going to do well, that 80 doesn't need it. So 90 out of 100, I'm giving my chemotherapy for no particular reason. So can we kind of figure out who these people are? So this is one of the provocative trial came up this year with a Galaxy trial. It's an observational study, actually, ctDNA. You can do the blood work. It is available commercially. It's called like Signetra testing. We do send it from India for about few patients who can afford it. And essentially after 4 to 6 weeks after the surgery for stage 2, or like even early stage 3, like 1 or 2 nodes positive. In those scenarios also, we can send the blood and look at whether there is circulating tumor DNAs are present or not. If they are negative, you repeat them after a few weeks or few months. If they continue to be negative, probably they are going to be negative. Those are the ones who do not need the chemotherapy. So in US now, we end up doing this, like do the signature test. That is mandatory before we can give the chemotherapy for stage 2 and stage 3A. And if the signature is negative, no chemotherapy. And if the signature is positive, they will get the chemotherapy. The major reason for this is oxaliplatin, one of the chemotherapy that we use in colon cancer, will cause significant neuropathy. I mean, you will see patients like coming after 5 years, I still have the neuropathy. So we used to give like 8 cycles of oxaliplatin. Now we have cut it down to 6 cycles. And some of the Folfox will have 12 cycles of oxaliplatin. Now we do only about 8 cycles, and then we omit the oxaliplatin to reduce the neuropathy. But even then, we will never be able to predict the neuropathy. Once they start getting the numbness, we are done. That numbness is not going to go away. We can do all the tests, give the pregabalin or whatever medication that you want to give. Nothing is going to take away the neuropathy. Especially if somebody is going to be more functional with the hands. That is a very terrifying thing for them. So that is one of the reasons I think this gains some importance for finding out like whom we can avoid the chemotherapy. So this one. So 45-year-old with a bleeding per rectum, rectal adenocarcinoma with lymph node involvement, clinical N1, no metastatic disease. What is the treatment of choice? I think this is something that all of us will encounter. Metastatic workup has been negative. The options here are surgery followed by radiation and chemo, surgery alone, radiation with chemo followed by surgery, and chemotherapy followed by radiation plus chemo or vice versa followed by surgery. So the correct answer will be like chemotherapy followed by radiation plus chemo or vice versa. And rectal cancer has become a pretty wild west. I mean, you can pick and choose what you want to do. 10, 15 years ago, everybody had the surgery, then went in for chemotherapy and radiation. And then around 2007 or 8, they said, okay, they need to get radiation and oral tablets, do the surgery, and then give the chemotherapy later. And then they said, do the total neoadjuvant therapy, give the chemotherapy, and then give the radiation and oral Zeroda, and then go for surgery and nothing else afterwards. And then they said, they did another trial which came up with a newer thing, which was presented last year at ASCO. It doesn't matter whatever you do, give the chemo and then do the chemo radiation, then surgery, or do the chemo radiation and then chemo and then surgery. Pretty much the results were similar. And whether you do short course or long course, which is also very helpful, especially in a setting like India, the short course radiation is extremely helpful, which is only 5 sittings of radiation, and then they can take them for surgery. Long course is almost like 5.5 weeks of radiation. So in a government setup, if you want to treat bulk of patients with rectal cancer, I think 5 days of radiation is very, very helpful. You can get it done with. The results are not inferior. Surgical techniques have improved so much that you don't have anastomotic leak and other things following the radiation. So that is one thing to think about whenever we consider a population to be treated as opposed to individual to be treated. So the same patient, N1 disease, no metastatic disease. The patient is saying, oh, I don't want to go for colostomy. I want to avoid the chemotherapy. I don't want radiation. And I'm worried about my neuropathy. I'm worried about this and that. Do I have any other options? Send him for palliative care. Do the RAS testing. Do the HER2/neu testing. You do the MSI testing. You can always say, like, Marshall used to say, "Get out of my office," which is something I would try to say sometimes, but I don't say it. Okay. So the MSI testing, I think that's 67% here. Oops, sorry. So what is the best predictor of immunotherapy? That is one thing that we all think about. You have the PDL1 testing, and then you have the high TMB or the EGFR mutation, or the MSI being high, or RAS mutations. There's another question, I think. And if you look at it here, high PDL1, high TMB, EGFR, MSI high is the correct answer here. That actually predicts that immunotherapy will work, not the high PDL1 actually. So this is the PDL1 blockade for the locally advanced deficient MMR rectal cancer, or basically the MSI being high. And this is essentially a single-arm phase 2 trial, which came up last year, and the update was done again this year. I think Twitter was buzzing with everything. All the Facebooks and everybody kind of talked about it. Patients with stage 2 or stage 3 MSI high rectal cancer received a dostarlimab. This was done at Memorial Sloan Kettering, 500 milligram every 3 weeks for 9 cycles. If there was residual disease, they got chemo-RT. If they had no residual disease, they were just followed up every 4 months. And then those who had residual disease were supposed to go for surgery. So overall response rate to dostarlimab and chemo-RT, and the sustained response, like clinical CR, 12 months after completion of the dostarlimab. So this is the actual pictures of those who underwent endoscopic CR and near CR and rectal MRI with 3 months and 6 months. 12 out of 16 patients completed the treatment with more than 6 months. This was in last year. We have update this year also. CR rate 100%. You will never see like 100% complete response rates in any of the trials. No evidence of tumor on MRI, on PET or endoscopy. Nobody received radiation. Nobody went for surgery. No progressive disease or recurrence. Patients have been followed up until about 2 years now. No grade 3 AE adverse events were reported. Though this is a game changer. So and this has been approved. The dostarlimab was approved last year just based on these 14. That's it. So you don't need a phase 3 randomized trial. If the drug is good, if the effects are good, you can get it done. You can get your approval with 10 to 15 patients. So all the 15 overall response CR. You would never see in oncology this kind of response in any of the tumors. So that is one thing that has been approved. It is available in US. Now you can use it. You can import it here also, actually. So 64-year-old with a left-sided colon cancer had a resection and he was on observation, developed abdominal pain, now has liver, lung and peritoneal lesions. Biopsy shows adenocarcinoma. What are all the molecular tests that will be needed? RAS mutation, MSI, HER2 new, BRAF, or send the NGS for everything if you can. Okay. Oops. Oh, got it. There we go. The answer will be like you send it for NGS for. That kind of gives you all the answers for all of these things can be done. That's it. Oh, Raghavendra Suresh. Great. To give you some idea about the EGFR, which I think all of us do know about Erbitux and panitumumab that we use in metastatic cancer. It was approved in 2004. To give you how medications change, initially everybody got the cetuximab. And then the response rate was about 10%. Then we got a bit better. We did the KRAS mutation that essentially ruled out about another 40% of the patients because they were RAS mutant positive. And then our response rates went up to 20%. Then you did the extended RAS or BRAF. Once you do that, there is only about 40% of patients are there, but the response rates are about 25%. And then we knew that only left-sided colon cancers responded very well to cetuximab, and then more than 40% response. And they have to be HER2 negative. They do very well. That essentially means that you are talking about 15% of patients. Response rate is more than 50%. So if you add or get rid of all these patients, like a left-sided colon cancer patient, HER2 negative, BRAF negative, RAS negative, advanced cancer, if you give them cetuximab and chemotherapy, you will achieve about 80% response rate. This is, we are talking all the way from 2004 to 2022. It has taken us 18 years to really figure out this medication is effective drug, provided you choose the right patient. Now we are getting better in choosing the right patients. And another one that we always talk about will be like, again, MSI high. And those who have MSI high in metastatic colorectal cancer, it is a pembrolizumab, which is a PD-L1 inhibitor, compared to chemotherapy. So if you use the pembrolizumab compared to chemotherapy, just immunotherapy alone is very effective. You don't have to give them chemotherapy. Once again, if you look at it here, in the first 50% of the time, chemo also works for the first few months. And just because the MSI is high, it works very well in the early stage, but in advanced cases, 50% works, but other 50% it doesn't work. So we still don't know what is happening with the other 50% of the patients who are MSI high. Hopefully in another 10 years, maybe before my lifetime, we will know what is happening to those people. So if you look at initial therapy for metastatic CRC, those with most of the patients, you can get away with chemotherapy and bevacizumab. And those patients who do not have any RAS or BRAF or HER2 mutations, you do the chemotherapy plus EGFR therapy if they are left-sided. If they are right-sided, then you use the bevacizumab. And if they are MSI high, we just go with only immunotherapy, no chemotherapy at all. And in these scenarios, for the immunotherapy, the preferred agent is pembrolizumab, because that's where we have most of the data. So what are the other options that we have in metastatic CRC? Look at the patient characteristics, that is very, very important. Look at the comorbid conditions, what are the adjuvant treatment that they received, age, performance status. Performance status is very, very important as to how they are going to do. So you start out with maybe like 10 patients. Look at the molecular characteristics, use the immunotherapy, or if they're all negative, use the cetuximab-based treatment. That'll be your first line. Then come to second line and the third line. Once again, look at the tumor burden. Are you able to resect it out? Can you get an R0 resection? Look at the location. And what does the patient want? This is extremely important. We all miss out. I've had a couple of patients only last week, all the way from Tirupur, metastatic colon cancer. So patient comes in, 5 family members come in, everybody comes in, I want everything to be done. That guy has extensive disease, 67 years. Performance status is 3, essentially coming on a wheelchair. So the patient's family want everything to be done. We have all these things, we can do it, not an issue. Whatever needs to be imported, you can import, nothing at all. Okay? All the markers are all negative. MSI was not high, and RAS was RAS was mutant. So I really don't have a whole lot of options. So I said, okay, we can try some chemotherapy, but most of them may not work, but we can try it out. So this is the discussion I have with the family, not with the patient. So then once everything is gone, 2 hours later the patient comes in just by himself with his wife. Wife is wheeling him in. He says, doctor, I have few mills. I have about 3,000 employees I need to take care of. All these ones, I don't trust in them. I have no trust. They think I'm coming to see you. I'm coming to see my lawyer to make sure everything is taken care of. Because I know I don't have much time. So whatever you want to say, please tell me. I will take care of my things before. So patient preference is very, very important. quality of life and toxicity profile is important. Think about it always. Just try to ask the patients some right questions. They will tell you what they want to do. So we have subsequent therapies. I won't get into the details. All this we have for the BRAF and we have for MSI high and HER2 NTRK fusions. When we do the NGS testing, this is the what you call like the gold mine, or you hit the jackpot. Like if you have the NTRK fusion or RED fusion, because you do have good medications for these things, or for the BRAF also. So if somebody has these things, most of the times you're going to find these things like less than 2% of the time. But if somebody has it, you have medications, oral tablets that will work extremely well. 80% of the time you will see the response. So these are the newer agents which have been approved so far. In 2023 that we have it. Pembrolizumab for the MSI high tumors, dostarlimab for the solid tumors, specifically for rectal cancers, entrectinib for the NTRK and larotrectinib again for the NTRK, dabrafenib trametinib for the BRAFs, selpercatinib for the red gene fusion. So we are progressing, especially in GI cancers also, especially with the rectal cancer now with the 100% batting rate or 100% hitting rate. I think we will be heading in that direction, hopefully in the near future. With this, I will end my talk. Thank you.
The next talk is going to be as interesting as this one. It's going to be delivered by Dr. Anil Tarigopula, who is a molecular pathologist. He did his post-graduation from JIPMER and has been trained in the Cancer Institute and is one of those people who will now tell us from clinical medicine to molecular medicine. Dr. Anil, the stage is yours.
I'm really grateful to Dr. Shankar Srinivasan, Dr. Prem Nayagam and Dr. Arul Prakash for asking me to talk in this August forum. I think I have put exhaustive slides for the talk, but I'll try to be brief about Okay, when you talk about molecular testing, it's been a buzzword for quite some time now, and it's become a normal practice to do NGS assays for most of the tumors once they are diagnosed. So when we were initially doing these molecular testings, we used to do single genes and in that 1 or 2 codons. But over a period of time, we have multiplexing, not only in terms of battery of tests, but also a multiplex, true multiplexes when you do multiple parameters for multiple genes of multiple patients in one run. That is what NGS has brought in. And I would like to just briefly cover what are the requirements for testing in, already it's been exhaustively discussed. I will talk about CS stomach. I'll talk about just a little bit colorectal cancer. So one thing is the work that is done in the laboratory actually affects the patient and it is directly the responsibility of the clinician also to ensure that the tests are done properly, a proper panel of tests is requested. So I'll try to take you through a small review of that, overview of this. Molecular testing in cancer diagnostics, basically molecular diagnostics is nothing but when you try to study a particular disease using DNA, RNA from the tumor cells, and some tests also require additional testing of normal tissues, non-tumor tissues also. For example, MSI. Okay, I'll come to that later. Now, it can be done on tissue, cells, or fluids. And we know that cell-free DNA is done on blood plasma, right? So, purpose of this is to diagnose, all this we know, but always ensure that you use standardized tests and it is relevant to the disease that you are testing. Quality assurance in the laboratory where you are testing the samples is very important, and accuracy and a short turnaround time is desirable for any assay. The consensus recommendations are to report genomic testing within 10 days. If it's a reflex testing, within 10 days from the time biopsy is taken. So most of us don't meet it, but the idea is to give a short turnaround time, otherwise it's useless. So NGS, as I already said, it's next generation sequencing. The other name of it is massively parallel sequencing. So earlier we used to study 1 or 2 codons in 1 or 2 genes, and each of them was an individual test. Now when you do a lot of analysis together parallelly in a single assay, that is what is NGS. So that's what the technology is. It's not the end, it's the means to achieve the end of finding the right parameters for testing so that you can treat your patients. Advantage of NGS is mainly that you can look at almost all the biomarkers relevant, except for few. There are limitations for NGS also, but this enables you to detect multiple biomarkers concurrently in a single test, and on a small amount of sample also. Ideally, you should have at least 10 nanograms of DNA. That is a very small amount of DNA required for one test, right? That is the power of this. Where you have smaller tissue available, send it for NGS, because you can do multiple parameters in the same test. Instead of sending it for a panel of tests, one by one, sequentially if you do, it takes time and also requires much more DNA. So this was about 10 years NGS has been in use across the globe, and in India I think last 7 to 8 years we have seen quite a bit of usage going up. So advantage is it helps you to detect copy number alterations, that is amplifications or deletions. It helps you to do sequence variants, that is any changes in the sequence of the nucleotides in the gene, and also gene expression. All these can be studied in one single test. So of course the test has to be designed properly, validated, all that is there. So we are expecting that even today, like HER2/neu, the gold standard is still FISH, because copy number variants, there is a limitation with the validated assays available today. But in future probably we'll have better assays coming in for even amplifications. Now, as sir has already pointed out, it's not just DNA sequencing. Through DNA sequencing, we can identify the sequence variants like individual point mutations or single nucleotide mutations. You can identify deletions, insertions, the changes that happen in a sequence. But when there is a fusion, you require to study the RNA, which is basically the mRNA that you cannot amplify RNA, so you convert it to complementary DNA through a reverse transcription, and then you amplify the cDNA that comes out of it. So you can do sequencing with the complementary DNA. One more thing to remember is the heart of all molecular testing is PCR, polymerase chain reaction. That is the chemistry behind most of the things. There is no technology available even today where you can identify the sequence of a single molecule of DNA. So everything has to be Xeroxed. Basically it's PCR, where a single copy or few copies are multiplied into billions of copies, bringing it to a status where it can be detected by one or the other assay formats. It can be a pH change, it can be a fluorescence that you study in the instrument like Illumina and NGS. There are two platforms, ION Torrent. So basically you have to amplify everything. So when you amplify, the other thing is when you send the sample also to the lab, you have to make sure that the sample is not mixing up with other patient samples. Even in the laboratory, when you process the samples, when sections are cut for molecular testing, it should be done in a pristine way. You should use a fresh blade and do it. Otherwise, you'll have MSI peaks coming from other patients also. So you can have contamination. When you're amplifying something, a small dot on a page gets Xeroxed into all the pages. We don't want to have things which are contaminating a sample and going. So remember that PCR is the strength of it, and it is also a requirement that we prevent contamination of the patient samples when you're processing, right from sample collection till data analysis. Now, as already mentioned, the NGS is a platform. It is basically a technology, just like a pen. We can write a small poem or a long book. So you can do few genes which are relevant to a particular disease, thus bringing down the cost of analysis, or you can do comprehensive genomic profiling. Now clinical exomes are coming in slowly. They are still in investigational this thing. There is no validated assay as of now available, but I think in near future we'll have even clinical exomes where you'll have large number of genes which are involved in tumorigenesis being studied in one go. Now, this is just to confuse you a little bit, to make you feel that NGS has multiple steps. So basically you have tumor, and other thing is everything goes through the histopathology lab. So for molecular testing, you not only have pre-analyticals, you also have a pre-analytical which happens before that. Right from sample collection to histopathology, what happens in histopathology, that also affects the molecular testing. So once you receive in the laboratory, you extract the DNA. Most of the tumor testing, somatic, testing is of two types, somatic and germline. Germline is when you try to identify something on something which has been transmitted across inheritance, right? And the other one is somatic, where a particular mutation you study is limited to the tumor tissue. It is not present, it's a tumor driver. Germline mutations, they can be promoted as a tumor. We know that you have autosomal and autosomal dominant recessive genes like APC and other things which participate in tumorigenesis. But when you talk about somatic, it is always on tumor tissue which is formalin fixed, paraffin embedded, right? From that we extract DNA, RNA. You do various steps of wet lab. There is in NGS you have a wet lab where actually amplification of things happen, and then you have various technologies by which you sequence it. You identify what is the order of AGCT, the nucleotides in your DNA sequences or the RNA sequences. Once the data comes out, so it's all in the form of data. The data is not information, it is not actionable. So it goes through a primary analysis, a secondary analysis, and a tertiary analysis. So each of them have multiple steps where quality control needs to be established. What is thrown out from the previous step is accurate, is reliable for being an input for the next step. For each of these, the laboratory needs to establish its protocols. So NGS inside the lab, you have a heavy bioinformatics involvement. Either you use validated tools, or if you have your own assay developed, you have a team working on it. So NGS has its own, it has its strengths, but mostly whatever NGS tests we do commonly in diagnostic labs, we have validated tools available in the form of bioinformatics softwares also. But applying the right software, applying the right kind of filters is very important. So there is no AI or there is no algorithm which will work without supervision. So supervision at every step in the laboratory is necessary. And when we list out the variants in the report also, somatic variants, that is variants which are tumor specific, they have certain nomenclature system. When you get a report, when it is clinically annotated, it should be either classified as TR1. These are variants of strong clinical significance with therapeutic, prognostic and diagnostic value. And evidences are also, these are defined by the levels of evidence. And when a laboratory reports a case to you, it should be tumor specific, site specific, patient specific. It should take all the clinical information, take all the literature into view and give these tiers of classification. Right, this usually you have, this is called tertiary analysis. What comes in your report every variant that you get should be classified according to these tiers for it to be, this is a standard way of classifying the variants. Okay, let us see first question. I think it's very easy to answer. So which of these statements is not correct about NGS as a test methodology? Next I have to. It's not moving. Oh, here's. It's not going. I think it's stuck network.
Here actually network issues are also there.
There it is not moving.
It's not moving.
No, it's good.
But here it's not present.
Question has not come, right?
Start presenting to the display report results on this site. What's wrong, sir?
Okay, no problem. I think it was already there in the talk. The false statement was that robust bioinformatics is not required for NGS, right? So other things are required. So we'll continue. I'll just cover few practical aspects of gastric cancer guideline recommendations for biomarker testing. There are already it has been covered. It's overexpression or amplification of HER2 and MSI by PCR NGS or MMR by IHC. These are recommended in cases of CS stomach in appropriate scenarios, which is already discussed. But when you do NGS as a methodology to identify amplifications also, you come across certain alleles for HER2 gene, which in some basket trials have been mentioned as actionable. That is some additional information if you get if you do NGS panel. Okay, HER2 is one of the 4 receptors in the EGFR family. It plays the role of an oncogene in cancer. It is located on chromosome 17, as already described. Intestinal type is known to be more commonly showing this HER2 amplification. So there are 2 test methodologies which are recommended. One is immunohistochemistry and in situ hybridization or FISH technology. So the recommendation is first have a proper morphology done. Then you do the immunohistochemistry because it is available in every histopathology lab, almost all histopathology labs which do oncology work, and it is quite reliable there. But certain a percentage of those tumors need to be evaluated by FISH because they will be equivocal on IHC. So what are the important things? One is, when you do an IHC, it is basically estimating the protein expression on the cell membrane of these tumor cells. So it is basically proteomics. So you need to ensure that tissue specimens, once they are biopsied, they are rapidly placed in neutral buffered formalin, ideally within 1 hour. But it should be as short as possible to ensure that there is no degradation of the biomolecules. Morphology will be retained. Even if you do the fixation after 1 or 2 days, the histopathology will be okay because you can still have dyes binding to the nucleus and cytoplasm, and you will be able to identify tumor. But all the molecules present in that, the DNA, RNA, the proteins, everything will be degraded. That degradation is quite quick. So you need to make sure that basically fixation is nothing but pickling the tissue. So you make sure that morphology and biomolecules are held in the state that in a workable state, right? And pathologists also should ensure when they score FISH or IHC, it should be on lowest grade tumor morphology. And always remember, FISH is the gold standard, but it is always reflex testing from IHC 2+. The use of IHC or in situ hybridization should be considered first. If you are doing NGS also, use it later because these are known to pick up more cases. Copy number alterations are not very accurate on NGS as of today. So this is how an IHC will look, right from left to right. The intensity of stain will be high or low. If it is less than 10% of the cells showing no any identifiable staining or no staining at all, that is IHC 0. 1+ is when more than 10% of the cells show very mild staining. Then there is moderate staining, and then you have intense staining, that is 3+. 0 is negative, 3+ is positive, nothing doing. 1+ is also negative. 2+ is equivocal, that you need to confirm by FISH. A certain percentage of them will come positive on FISH, and some of them will turn out to be negative. So in some countries like Australia, they do in situ hybridization first and then also add on. They give more preference to in situ hybridization compared to IHC. But most of our protocols, whatever we follow in our country, IHC followed by FISH. Sometimes we do both because there could be challenges with protein expression also. So this is an example of a case. Ideally, we have to move from reporting morphology separate, immunohistochemistry separate, and FISH and other things separately to an integrated reporting format. So you have a surgical pathology report which says invasive moderately differentiated gastric adenocarcinoma by IHC done in the histopathology lab. It is equivocal, score 2+. So molecular testing was done by FISH, and here and scoring on FISH is a very important affair because it's not eyeball indexing. You have to actually see cell by cell and note down the different signals and then take a ratio and also the absolute number of signals per cell, average of that. So final diagnosis based on these analysis was reported as negative for HER2 amplification. So what is the algorithm that we follow? We follow HER2 immunohistochemistry test first. 0 is negative or 1+ is negative, 2+ is equivocal, reflects to FISH, 3+ is positive. Don't need to do FISH on those cases. So NGS for gastric cancer as of today, I mean, of course, if patient can afford, you can do any test, but where tissue is limited in availability because you can do multiple markers on a small amount of tissue. With adequate DNA and RNA from one tissue, you can do a lot of things. So this is recommended in certain scenarios where you have FDA approved drugs to identify like tumor agnostic, tissue agnostic markers, and also for HER2 overexpression also you can report, but it should be an assay. The NGS assay must be validated for HER2 amplification. Not all assays are. So where you do not have tissue available or it is a challenge to take a tissue, you can do a liquid biopsy. Basically, it is cell-free DNA. This is a little challenging because the sample is very pristine. The plasma can get contaminated by lysis of cells in the blood also. So it will become right from cell-free DNA itself is like picking a needle from a haystack. It will become picking a needle from go down. So there are certain precautions that have to be taken whilst handling these samples. Okay, the slides, questions are not coming. Okay, next we'll go to GIST. I'm just talking about the biomarkers which are recommended for testing as of guidelines recommendations. The diagnosis by morphology is on microscopic examination and this is the standard of diagnosis is morphology, that is microscopic examination of the tumor, and then most of the times because you have spindle cell, epithelioid, pleomorphic, you have all sorts of dedifferentiated GIST. It is almost always a requirement. It is mandatory usually to have ancillary techniques by immunohistochemistry for SDHB, CD117 that is c-KIT, DOG1 and CD34. And in some cases, you will even have to do KIT and PDGFRA mutations because immunohistochemistry may also be confusing in some of these cases. So this is just to show you what are the differential diagnoses in spindle cell variants and epithelioid morphology and how immunohistochemistry and molecular testing can help. So molecular testing is predominantly, if you have KIT mutations, PDGFRA mutations in tumor which is looking like GIST, it is, and with varied types of immunohistochemistry profiles which is available, supportive and sometimes non-supportive, you can call them as GIST. So KIT and PDGFRA mutations are not only predictive markers, but they are also diagnostic markers in some cases. And it is not only important to identify the mutations in KIT and PDGFRA, but also important to identify which exon is mutated because therapeutic decisions are going to change based on this. I'll show you the examples of that. One more thing is this risk profiling is used in both gastric and non-gastric GIST. This is applicable only to KIT PDGFRA mutated GISTs. Any other mutations or SDH pathway GISTs are not, they are not, they do not, they are unpredictable and they do not perform as per this prognostic profiling. And I guess all of us know that we take the tumor size mitotic rate for risk stratification. That does not work with non-KIT or non-PDGFRA positive GISTs. So if you take the molecular biology of GIST, you have succinate dehydrogenase competent and succinate dehydrogenase deficient. This is not necessarily the way we test for GIST. SDH competent GISTs are mostly because of mutants in KIT and PDGFRA, which constitute 80% of GISTs. Apart from that, BRAF, in cases with KIT negative, you can have BRAF, NRAS, HRAS, KRAS, and now recently EGFR mutated GISTs are also described as drivers of tumorigenesis. And there are also other markers, including fusions, where you have NTRK fusions, you have FGFR1, KIT PDGFRA. KIT and PDGFRA are located on the same chromosome, and they are in close proximity. Sometimes there is a fusion product of those two also. Then there are 5% of, about 5 to 10% of GIST can be SDH they may be negative for all these mutations, and some of them turn out to be to have loss of succinate dehydrogenase. That could be because of a mutation of the succinate dehydrogenase gene, or it could be because of the silencing of the gene. So we all know this Carney's-Stratiscase syndrome and Carney's triad are associated with this, usually seen in young adults and children. Now, when you talk about KIT and PDGFRA mutations, if you see in KIT mutations, 70 to 80% of mutations are on the exon 11, which is the juxtamembrane domain of the KIT molecule. And the next commonest is the exon 9, which is 10%. There is a difference between these two exons. Identifying the location of mutation is very important. In case of PDGFRA, most of the PDGFRA mutants are located on exon 18. which about 5% of all the KIT PDGFR mutations combined. And in this, it is important to identify D842V separately also. There is a reason for that. I'll enumerate that. Now, we have seen that 80% of GISTs are KIT and PDGFR mutated. And if you see, it is important to identify KIT exon 9 mutation, which has a lower response rate and progression-free survival than exon 11 tumors at a certain dosage of imatinib. The same mutation, when given a double dose of imatinib, is associated with a better PFS. So it's important to identify where exactly your mutation is located. And PDGFR mutations usually show response to imatinib. Exception is D842V mutation, which is shown to respond to avapritinib and dasatinib also to some extent. Now there are also secondary mutations which can cause metastatic disease progression on treatment or metastatic disease due to acquired drug resistance. Because all these genomic, even the genomic lesions tend to progress over a period of time, either through clonal selection of something which was missed out in the initial assay because of limitations of the assay, like heterogeneity could be a reason for that, or there could be acquisition of new mutations in the sequences. Now, tumors which lack KIT or PDGFR mutations account to about 10 to 15% of GISTs, and these are, majority of them have functional inactivation of SDH complex, the succinate dehydrogenase complex, which is part of the citric acid cycle molecules. Now, you can do a simple IHC to detect SDHB depletion on the, or loss of SDHB on the tumor cells. Now, inactivation of genes can happen when there is a mutation causing loss of protein expression, or it can also happen because of silencing, because of promoter region being methylated. So one thing which is important is referring to a genetic counselor for germline testing assessment is recommended for all patients with SDH deficient GIST and those with GIST that have neurofibromatosis 1 or SDH mutations, because there could be a hereditary component in that. Other thing to note is that patients with SDH germline mutations, they are part of, some of them are part of Carney's triad and also CSS. So those have a risk of having a paraganglioma. So 24-hour urine testing is recommended prior to surgery in those cases. So basically for functional aspects, we have KIT PDGFRA mutated GISTs and wild type KIT PDGFRA GISTs. So I won't go into the details of this. Now, this I have already told you, it's important to identify exon 11 and exon 9 separately for KIT mutations. And in the case of PDGFRA, identifying D842V in exon 18 is also important. Okay, next is about colon cancer. Colorectal cancer, for purposes of molecular biology, colon or rectal or colorectal, there is no difference. So entire gamut of colorectal cancers are taken as one subject for studying the colorectal cancer. Microsatellite instability is when you have certain problems with DNA mismatch repair, where cells are getting replicated, there is no proofreading. Somebody has typed it, without proofreading it gets published. So that is the problem with MSI. Now, whichever pathway you take up, I mean, these are the three main pathways. Whichever pathway you take up, KRAS is common to all. You cannot just say that because it is MSI, I will not do KRAS. KRAS is seen across. It can be a passenger mutation, it can be an oncogene driver or a promoter of disease. Usually it arises very early in colorectal carcinogenesis, but it's known to appear later on also as a passenger mutation picking up in clonality at a later point of time. So let us see, like we have seen cetuximab, panitumumab being used. So basically this is the same EGFR which is targeted in lung also, but here you're not targeting the EGFR, you're targeting the EGFR at the receptor level rather than at the tyrosine kinase domain. In this case, the downstream, once EGFR, for it to be active to promote cell growth and proliferation, survival of cell, it needs the ligand, that is the growth factor has to bind to the EGFR. When growth factor is not there, it should not be active. But in this particular case, if there is a KRAS mutation, which is a downstream, if there is a short circuit or something where KRAS is constitutively activated, activating mutations of KRAS will keep the pathway active irrespective of whether there is a blockage at the receptor level or not. Cetuximab, panitumab will not be effective if there is a KRAS mutation downstream, which activates the pathway by itself. So there are certain hotspots. When you talk about mutation analysis, remember that all the mutation analysis you do in NGS is not the entire gene coverage. Lot of them are hotspots. They only interrogate regions which are known to bear most commonly, recurrent mutations in various tumors, in proportions of tumors. Only those are targeted. So bare minimum requirement is to have these hotspots covered in the assay. And sometimes, like sir also said, with the improved testing and all, we are able to identify cases which will respond better. But one more thing which is important is it's not just the EGFR pathway, it's the PTEN, TGF beta and Wnt signaling pathway, which all have a crosstalk. So there could be a case where you do not have KRAS and RAS mutations, but you do not have response which is good enough for cetuximab, panitumab. Also at the receptor levels, there is transactivations and there are drugs available. So all these mutations, signaling pathways which are cross-talking will be identified if you do a comprehensive testing. So you will know what are the things apart from just the wild type KRAS that you need to look at to see whether these will be effective or not. And there are drugs available. And you have de novo drug resistance because of KRAS mutations and also acquired drug resistance. It's not just because of KRAS, it is because of a list of markers which you need to know. Not necessarily as medical or surgical gastroenterologist, but for a treating physician who is taking care of this, all these, when you read an NGS report, you identify any of these. These may not respond to the EGFR markers, but there could be some other drugs available, as sir has already mentioned. About a tumor heterogeneity. Now, every test modality also has a limitation. There is a limit of detection for every assay. It's a sampling, like sir has already shown, if you take from different parts of the tumor, you may have different results. So in this particular case, most of the gray areas are the ones which are sensitive tumor cells, and the various other colors are the ones which are resistant. Two things can happen. Either these were present from beginning, which were not detected by the assay that you have done, or over a period of time, genomic progression has happened and you have acquired resistant mutations. And over a period of time, when you give a therapy which targets these sensitive cells, there is a pressure, clonal progression happens for the cells which are under therapy pressure. The cells which are resistant get selected out and they get detected in the further assays when relapse happens or you have a metastatic disease. So there are different theories for this resistance also. So recommendations for molecular testing is already informed. KRAS, NRAS, BRAF testing, microsatellite instability or mismatch repair testing, HER2 testing and NTRK fusions. But NTRK actionable is only the fusions, not the point mutations which may get you may get as part of your NGS report. Now about NGS, about KRAS, NRAS, BRAF testing, this already discussed. Only thing I would like to point out is there is a negative recommendation to use unmodified Sanger because the sensitivity of Sanger testing, the initial sequencing that we used to do was Sanger sequencing. Some people are still doing it in the country for these genes and it is discouraged. There is only one negative recommendation about technology. Don't use Sanger testing because it will not pick up mutations which are less than 20% mutant against the wild type in the sample that you are sending. About microsatellite instability, 15% of all colorectal cancers are known to show microsatellite instability. About mismatch repair genes and microsatellite MSI, these are trying to measure the same system. Remember, MMR is the product of the gene which is involved in proofreading of the DNA replication. Right? When the DNA is replicating, certain errors do creep in. Before it is actually taken up as final, there is a proofreading which happens. MMR genes are involved in proofreading of the DNA where syntax is read and errors are corrected. Now, the effect of a DNA mismatch repair, deficient mismatch repair, if there is a problem with one of the genes, either by mutation or silencing, the effect is microsatellite instability. So there are certain molecules, there are certain nucleotide sequences which are called as microsatellites. These are nothing but 1 to 6 nucleotide sequences which are known to be distributed across our genome in various chromosomes. And these are, these particular things, you have mononucleotide A13, for example. A is appearing 13 times, right? So when a typist also types, in a quick way, when it is typed, it can be something like 12 or 14, right? The same error can happen when the DNA polymerase is replicating the DNA. Any shift in the nucleotide sequence is going to change the codon, like you know the codon, triplet codons giving rise to amino acids. A frame shift mutation, when it happens, when the frame of the DNA shifts, you have errors. So the genes become silent or the mutations creep into the gene, right? So that is the concept of microsatellite, is a way to pick up deficient mismatch repair. Deficient mismatch repair you can either pick up by doing a sequencing of the MMR genes, which is a later step, but basically what we do is IHC to identify loss of expression of mismatch repair gene proteins. So there are the Bethesda criteria for MSI testing clearly gave some phenotypic differences, but though these phenotypic differences occur, it is always important that we do by experiment we prove whether MSI is present or not. These are not surrogate for presence or absence of MSI. Now, one thing which I have seen an aberration, there are labs which are doing just tumor testing for MSI, which is not by definition. Microsatellite instability is studied by doing a tumor analysis and comparing with the normal. There are labs which I myself have assessed for NABL, where people were doing for more than 7-8 years just the tumor part, but it is always a comparison. Why? Because these microsatellite markers that we have chosen from the Bethesda system, they are quasi-monomorphic. Why we use these markers is across the 8 billion population, the same sequence is present in those targets, right? But they are quasi-monomorphic. There could be few of the markers with two, in a given population you may have two variants. If you do only tumor testing, you may actually pick up biallelic signature of certain 1 or 2 markers, which you will wrongly label as MSI high. So tumor normal comparison is mandatory in MSI testing, whether it is by PCR followed by fragment analysis or by NGS. So if a lab is doing only tumor testing, it is not accurate. You may be overcalling MSI in some of these cases. So MSI is also one part of MSI is contributed by germline mutations in the MMR genes. So what is the workflow that we recommend? See, MSI PCR test and mismatch repair by IHC, these are two separate things which are complementary to each other. So like to identify MSI, the PCR test is the gold standard. You do an MSI PCR test. If MSI high is more than 40% of your markers showing positive for being positive for microsatellite instability, it's called MSI high. If 1 out of 5 markers is positive, that is 20%, less than 40%, it is called MSI low. MSI low and MSS, that is microsatellite stable, are effectively the same group. MSI high, you subject to MMR IHC test, both should be done, and then if you have MLH1 or PMS2 loss with BRAF mutation or MLH1 promoter methylation, it is almost always sporadic. If you have MLH1 or PMS2 loss without BRAF mutation and without MLH1 promoter methylation, there is a high probability it could be Lynch. Only way to diagnose Lynch is by actually sequencing, the actual complete sequencing of the 4 MMR genes.
Dr. Anil.
Yes, sir.
Yeah, next 2 minutes, can you finish?
I'll try to wind up, sir. Okay, this is an example. I think everybody will be familiar with these reports. I think questions are not coming, but yeah. So one thing that is very important from a clinician perspective is there is a lot of pre-analytical doubts, whether tissue, whether fluid, whether cytology, whether FNA, whether FNB. So any tissue which is representative of the tumor that you are studying can be subjected for molecular analysis, provided it goes through a morphology evaluation and confirmed that there is tumor, adequate tumor is there. You can even scrape from a cytology smear extract the DNA and RNA and use it, provided there is an evidence, you have evidence that it has tumor cells in it. Right? The ideal fixative for cytology specimens, if it's a smear, is going to be alcohol. If it is tissue, it is always neutral buffered formalin. And don't put into any other saline or anything else. Every tissue which goes for morphology will only go for molecular testing. So nothing goes from direct, nothing should ever go from the clinician's thing directly to the molecular without being in the fixative, without being through a microscope. You have to know that there is tumor, there is a proper diagnostic material in that it is representative of the disease that you are studying. So I just wanted to, in any laboratory process, there is an analytical and pre-analytical phase. Pre-analytical phase for molecular, you have an additional step of what happens in the histopathology lab also. So responsibility of the molecular lab is also to interact with all the stakeholders and see that there is effective communication to ensure proper tissue comes into the lab, a proper evaluation is done. There should be a protocol for doing your test also, and reports are also to be conveyed in appropriate way. Now, specimens can be FFPE blocks. You can have cell cytology. When you have fluid, if you have an ascitic fluid, don't send 10 ml and discard 500 ml. If you have 500 ml, send it to the lab. They can spin it down, get all the cell blocks done. And if you have multiple small tissue bits you are taking, please instruct the laboratory to make multiple blocks. If they make only one, if they put 8 tissue chunks into one block and make it, each time they cut for IHC, entire tissue is going to be sectioned. So how you manage your tissue is also important. So sometimes you can actually take two chunks of tissue, put in the separate containers and send. And please clearly instruct your histopathology lab to optimize it for further downstream testing also. So that communication should be very clear. And one more thing which is important when you are doing an FNAC or an FNB, have a rapid on-site evaluation of the specimens that you are taking, because procedure it's very it's not only time consuming and effort making, but also we should ensure that whatever sample is sent to the laboratory for evaluation is representative, and there is no complaint tomorrow that there is sample is not sufficient or it's not representative. A rapid on-site evaluation can be done for almost all cytology specimens, or even small if you have an imprint or something, you can see that. So that level of communication and interaction should be there. So there are various pre-analytical variables in molecular testing. One is cold ischemia time, which can occur because of delayed fixation of the tissue. Try to put the tissue immediately into neutral buffered formalin. Then there's a lot of variables in the histopathology lab, and also a lab which is doing molecular testing should have an enrichment protocol. Other thing is archived tissues which are more than 6 months to 1 year old will have degradation and formalin induced artifacts which will give you false positive results on NGS. So archived tissues, sometimes they may not amplify, DNA may be fragmented beyond point. So those things you have to be careful. Asking for a test in time when the sample is not very old is also important. So always plan your molecular tests ahead of sampling. When you know that it's an oncology case and you want to send a sample for further testing, discuss with the laboratory, sample appropriately, and also ask the laboratory, give clear instructions to optimize it for further downstream tests. Now, one thing I want to imprint in everybody's mind is formalin fixation is a physicochemical process. It's an irreversible chemical reaction which causes cross linkages between DNA, RNA protein, everything. So basically it makes the biomolecules preserved. Biomolecules are only active if their quaternary structure and all is maintained. So when there is extensive cross linking of these biomolecules, the tissue gets preserved. So fixation should not be less than 6 hours and not more than 72 hours for optimum results. You cannot send a sample at 6 o'clock, tell them to put in the tissue processor, by morning I want the results. Downstream, your IHC, your DNA, RNA profiling, everything may get affected. Minimum 6 hours, maximum 72 hours. More than 72 hours, the chance of over cross-linking and not being able to retrieve the RNA, DNA from the sample is going to be there. Even for IHC will look dull and you may have false negatives in that. So fixation is a very important part of tissue process. And FFP itself induces a lot of artifacts. If those artifacts the laboratory does not take care of, those artifacts will be reported as true results. So C changes to T and G changes to A in an NGS thing So there is a way in which your bioinformatics team should evaluate whether your tissue is showing formalin artifacts before reporting out somatic tumors. Okay, so this is the last slide, and it summarizes that it's important and we can do a broad panel testing based on requirements. A clear communication is a requirement. So sample tissue is the issue, but tissue is also the best thing to evaluate for these tumors. When tissue is not available, you can use cell blocks, you can use fluids which are positive for tumor, you can use cell-free DNA. Biomarkers can also be evaluated on various matrices like CSF, urine. Those are also known. But the commonest cell-free DNA evaluation is done on plasma, blood plasma. Thank you.
I'm sure you'll all agree that these two lectures have shown us a paradigm shift in how to diagnose and manage oncological lesions in the future. I didn't understand much of it, to be frank, and I don't think many of you understood, but it is important because over the next few years, this is how we are going to manage oncology. See, for example, when we were students, we had histopathology. We were very, very happy that we could diagnose. And then we had cytology. You send ascitic fluid and then cytology positive, so we were thrilled, we diagnosed malignancy. And then it was not enough, then we had immunohistochemistry. Now, a diagnosis is not complete without going into the molecular structure. So that is because that is the basis on which the treatment is going to be planned. So this is very, very important. So we didn't understand much, but certainly we have to follow it up. And because the next decade is going to be oncological molecular diagnosis and further treatment.
I think the topic is now open for discussion. May I ask the first question? Now, as far as I understood, you're looking at pathways which, when mutated, produces a repair, and therefore the repair is not corrected, and therefore tumor occurs. You also say that during chemotherapy or during immunotherapy or during treatment, mutation could still occur, and therefore the drugs which you're likely to give may not be effective over the long run. I mean, this looks like a paradox to me.
So there are two things. One is there could be genomic progression of the disease. As the disease progresses, there could be additional mutations which happen. Like MSI is there, it is going to keep on. It is already there. You are targeting it, but there are a certain number of cells which will still progress. And over a period of time, the cells which you are not targeting, like there could be a mutated KRAS somewhere hidden in your tumor which was not there in the assay, or your assay was not sensitive enough to pick up every assay. There is no perfect assay. There will be something missed out on every test. There is no perfect test. So there is a limit of detection for every assay. You might have missed out in the first time. But because of therapy pressure, the clone which was sensitive has got removed. The clone which was resistant, that progresses in disease. Second is that is heterogeneity of the tumor. The other one is genomic progression, where additional mutations accumulate over a period of time in the tumor cells, and tumor acquires better survival and better proliferation capabilities because of the pathways being activated.
Sir, one question is, we have pre-malignant lesions, for example, Barrett's and then colonic polyp. Is there any way that we can predict that this might, by molecular study, whether this will go into malignant change?
As of now, no.
Any other questions from the floor?
Do all cancers, I mean irrespective of GI cancers, do they have molecular testing? Every single cancer in there?
So cancer is a molecular, I mean this is based on molecular changes.
No, I'm saying, are you going to look at proteins on the surface? Are you going to look at the pathways in every single cancer? Is it been worked out that these particular drugs?
I think it's still a work in progress, sir.
Yeah.
Last one decade has been quite.
Yeah, the recommendation right now is to do the NGS testing for all the cancers and some of the hematological malignancies, not for all the hematological malignancies. So in that way, I think we will have a better idea. Is it hopefully in another 10 years, we will have better drugs or anything available.
I'm very happy to be a clinician, just making the diagnosis and then passing the buck. The only problem comes when the patient comes back to you because he doesn't understand you. He comes back to us and says, "Sir, care to solunga sir." Response
True.
So
Thank
only
you
thing
very
is,
much.
I want the clinicians also to understand that the laboratory is owned by the clinicians.
Yes, I know.
Because the work happening is there is going to, it's not my patient, right? What I do is affecting your patient. So, I mean, in future, I think the clinicians will have to understand what happened. Not they need not come and work in the lab, but they should know what is going on. You should be able to know whether the assay being done is correct over a period of time. It's all new for everybody now.
There's a lot of homework, so we have to catch up.
Yes.
Thank you very much, Dr.
Thank you, sir.
Dr. Srinivasan. We'll close the session and invite Dr. Arul Prakash to give the vote of thanks. Dr. Arul Prakash.
So once again, sir. Thank you, Chairperson. I would request you to felicitate our guest speakers. I will request Professor Rajnikant to felicitate Dr. Shankar Srinivasan. Thank you, sir. Thank you. It's time to thank, and it's also a time to congratulate. And we got a news that the health secretary have appreciated the medical gastroenterology department of Rajiv Gandhi Government Medical College for performing the largest number of procedures in the last few months. And as well, as a single person, Dr. Selva Segaran from Thuthukudi Medical College has performed largest number of procedures, and he also got an appreciation from Health Secretary. We should congratulate him. And it's time to thanks the postgraduates, the chairpersons, guest speakers, and dear colleagues, and ISD Tamil Nadu chapter patron and president, Professor Epan, and the other council members for attending and making the CMV successful. And we can now join for a cocktail dinner. Thank you. Thanks for attending the session.